All right, good morning. Good, camera looks good. Okay, good morning.
Sorry, I was adjusting. There we
Oh,
go.
okay. Is everybody receiving our wrap-up emails? Is there anybody you're not? Okay. See me after class. Let me verify your email address and make sure that we've got, so I can make sure that you get the wrap-up emails. Everybody else good? Because those have links that will be helpful to you for review and things like that. All right, so over the weekend, you guys had 2 chapters of homework. I know it was long. These are very long chapters. I get it. But do you have any questions about what you read? Any questions? A question I get asked a lot is that I think it's chapter 2, it talks about 75 hours being required for licensing for CNAs. Florida is the only state that does not abide by that federal guideline. So in Florida, we allow challenging. That means that you can take the test without any experience or education or training or anything required. You can just sign up for the test and take it. So that 75 hours is not required for Florida. However, it is important that you know that, because in some settings or some states, if you want to transfer, let's say that you want to go to Tennessee may not give you a certification just because you have one in Florida, because they know that Florida allows challenging. So although you're allowed to challenge in Florida, remember it may restrict your ability to transfer or get another certification in another state based on the fact that you have one here. Now, most states, the majority of states, do reciprocity. Basically, they give you one there because you've got one here. But there are a few that that 75-hour thing is going to trip you up a little bit. If you're looking to move out of state, you'd want to research that before you go. Okay. All right, so chapter 2 and 3, you read, you took the test, and then you graded it using the answer key on page 201. Let me go ahead and get your scores. Candy? Thank you. Tyler? Okay. Do you have chapter 1 for me by any chance? Okay, that's fine. Josuel? Thank you. Sonia? Thank you. Amaris? Thank you. Elena? Thank you. Claudia? And Alyssa? Thank you. All right, so chapter 3. Do it again. Candy? Tyler? Yep. Josuel? Sonia? Amaris? Elena? Claudia? Alyssa? Okay. All right. Okay, so tonight you'll have one chapter. You'll be doing chapter 4. Chapter 4 is on body systems. I don't like chapter 4 in the yellow book. I think they make it overly complex. It's not stuff that CNAs are going to be tested on or need to know. What you do need to know are normal signs of aging by body system. What's normal? Because remember that half of our job is observation and reporting. If we don't know what's normal, how are we ever going to identify abnormal? Does that make sense? So that's what I want you to focus on in chapter 4 for tonight's homework. So let's do a quick review here of all of these principles. CNAs are going to perform the skill as directed on the care plan. We follow the care plan, the whole care plan, and nothing but the care plan. While we're doing the tasks on the care plan, we should also be observing. And then who do we report those observations to? The nurse. Very good. All right. Every skill starts with the opening. Every opening starts with a knock. After we knock, who are we going to greet? And how are we going to do that? By name. That's right. That's right. What do they need to know about us? Name and title. And then we're going to tell them, yeah, what we're doing. Absolutely. And that's because we need to get that permission, consent. Once we do that, we can close the, is that curtain clean? No, curtain is not clean. So after you touch that curtain, what do you need to do? Wash your hands. And then we'll get our supplies. Remember our big rule here, the big neon sign rule here is do not touch the patient until your hands are clean. Remember that. Great job. Sometimes we're going to need to wear gloves. Should we wear gloves for everything all the time? Why? Why? That would be so much easier. If I, as a teacher, could just stand up here and say, hey, wear gloves for everything all the time, man, I could skip like 2 whole hours of lecture. That would be easy for me to do. Why can't I do that? Okay. The problem is when you wear gloves all the time, you're going to transfer pathogens from one place to another because you stop thinking about what those gloves are actually there for. And accidental pathogen transfer happens with gloves more than anything else because we stop paying attention to what we touch, and that's a problem. So how do I know when I should wear gloves? If I'm going to touch body fluids, okay, personal skin, or what other kind of skin? Non-intact skin, that's right. So body fluids, personal skin, or non-intact skin. What's the first thing that my gloves should touch? Oops. If I'm going to wear them? The patient. And this is the hardest thing about wearing gloves for you guys. You're going to trip over this a million times because when you're doing the skills, you're going to want to get your supplies, and then you're going to want to put your gloves on before you start prepping your supplies or your patient or all that. Remember, everything those gloves touch will contaminate the gloves before you use them. If somebody were brushing your teeth, would you want gloves in your mouth that touched a lot of stuff or gloves that hadn't touched anything? So we have to really stop and think about that when we're going to put our gloves on during these skills. And you will trip over this in practice. You will. And remember, we don't really get a lot of practice in until next week. Week 3, you'll have some practice built into the program. And you'll see what I'm talking about. As you guys are practicing, you'll start to realize, oh my gosh, I put my gloves on too early. It's instinct. It's always, trying to put your gloves on before you really start the skill. But if you can remember this, the first thing the gloves should touch is the patient. If you can remember that, it will always tell you when to put your gloves on. So after we wear gloves, we have to pay attention to what else we're touching in that environment. Remember that pathogen transfer from gloves is the #1 way that things get distributed in a patient care environment. So we've really got to pay attention to what those gloves touch. And then if we do wear gloves, we also have to know how to remove them correctly. Dirty glove can touch dirty glove. Dirty glove cannot touch skin. So we've got to remove it correctly. We also learned how to use a barrier. And remember, a barrier creates a clean place for our clean supplies. Barriers all about clean, all about clean. We don't want to touch the supplies until our hands have been cleaned. Remember, barriers all about clean. So we can only touch supplies with clean hands. We don't want the supplies to touch our uniform because our uniform is not clean. Barriers all about clean. So in order to keep that those supplies from touching our uniform, we're going to go get that barrier first, put it on our table, then get our supplies and put those on the table. That keeps you from holding your supplies up against your uniform while you're trying to spread out that barrier. All right, we also learned about privacy blankets. Why do we use privacy blankets? What do privacy blankets do? They keep the patient warm and covered. Remember, we don't want to see knobby knees, right? Always covered. So they keep the patient warm and provide privacy. We're going to use it anytime the patient is uncovered or undressed during a skill. To use a privacy blanket, we're going to spread it out over the sheet and pull the sheet down underneath so the patient stays covered at all times. And we aren't going to snap or shake that blanket as we put it on the bed. That just aerosolizes all the pathogens. We remove it at the end of the skill after we remove our gloves if we wear them. If it's a skill that requires gloves, then we remove the privacy blanket after we take the gloves off, because you don't want to touch that sheet that's going to go right up next to their face with dirty gloves. Remember, gloves are the biggest culprit in pathogen transfer. All right, we also learned linen rules. Boy, we learned a lot last week. We also learned linen rules. Now, linens can't touch your uniform. We've already gone over that. We also know that you have to have clean hands to get your clean linens. And we know not to shake or snap the linens. So there's nothing really new so far in linen rules that we aren't familiar with. Now, the next two we're going to skip. We'll get to those in just a few minutes. And we're going to go down to the bottom. And the last one is unused items must be discarded. You cannot keep clean linens in a patient environment and still consider them clean, because once they're out of your sight, you have no idea what happened to them. So unused items, anything you don't actively use, we've got to put in soiled linen. We'll get to the other two a little bit later today. And then we learned the closing. The closing, the order of the first couple steps don't matter, but the patient needs to be in a clean environment. We think clean and safe. So clean environment, and the bed needs to be in the low position. We want to ask about comfort. They need to hear that word. Are you comfortable? And we're going to address preferences. Is there anything I can get you while I'm here? Would you like a magazine? We're going to address preferences. Remember, this is all about the patient. This is how we show them that it's all about the patient. Otherwise, your closing kind of sounds like this, okay? And this is what we want to avoid. All right, Ms. Jones, I'm done with my skill. There's your call light. It kind of feels incomplete to the patient. But let me tell you another reason why this is so important. And it all has to do with time management. You guys, as CNAs, are going to have way too much to do and not enough time to do it. That's just the sad reality of life in healthcare right now. Too much to do, not enough time to do it. So if you're rushing through these skills and at the end you're like, okay, I'm done, here's your call light, got to go, and you leave, that patient probably has something that they need. Now, remember, if they were home in their own environment, they would get up and get whatever it is they needed. They would do for themselves whatever it was that needed to be done. But they can't. If they could, they wouldn't be here. So they can't do these things on their own. So if I've got a patient that's in bed that needs help with things, and I rush out of the room, that patient has nothing to do but focus on the thing that is driving them nuts right now. And they will try, because they know you're super busy, they will try not to be a nuisance, but they're going to focus on it. And it goes something like this. Oh boy, I'm really cold. It's so cold in here. I'm so cold. I'm shivering. I'm so cold. I can't help it. I hit the call light. You come in. How can I help you, Miss Jones? I need a blanket. I'm freezing. Oh, okay, no problem. Let me go get you a blanket. So you go get a blanket. You bring it back to them. Anything else? Nope, I'm good. You leave. Now the patient lays there for a little while and they get thirsty. I'm thirsty. I'm thirsty. They have nothing to distract them. Now, if they were at home, they would get up and go get their own drink, but they can't. They need our help. So what do you think they do? hit the call light. I'm thirsty. Okay, let me go get you something to drink. You go to the nutrition room, you get them a juice or water or whatever, bring it back to them. Okay, you leave. You go take care of another patient. And after about 15 minutes, they hit the call light. They're like, I got to pee now. So you get them up, you get them to the bathroom, take care of that, get them back to bed. 15 minutes later, they hit the call light because they want a crossword puzzle book from their closet across the room. And this goes on and on and on. Now, if you've got 10 or 12 patients that are constantly hitting that call light, what's going to happen to your time management? It is out the window 100%. And that is reality, guys. That is what happens. Absolutely. So in order for you to get good time management, you need to take care of everything this patient needs while you're there. Because remember, every single time I left that room and I came back, I had to wash my hands. That's a lot of time. And then I leave, I come back, I got to wash my hands. After I'm done with whatever it is they need, I got to wash them again. It's just a lot of time. Where if I'm here and I say, thank you very much, Miss Jones, is there anything else you need while I'm here? This gives her an opening. It gives her an opportunity to go, yeah, I'm a little bit cold. Do you mind getting me a blanket before you leave? It's a whole lot quicker to do it now than it is to do it when I'm in the middle of something 10 minutes from now. Are you thirsty? Would you like something to drink before I go? Need any toileting help before I go? Getting all of these things taken care of will help you devote your time to the next patient 100% without a lot of interruptions. Does that make sense? This is how you control time management, is through this right here. Making sure that you're not rushing the closing and you're taking care of this patient completely before you leave their environment. That keeps them off the call light. What a lot of CNAs do out there instead is they hide the call light. Remember, if these patients can't do these things themselves, they have to rely on us. Hiding the call light is neglect. Does that make sense? Okay. So we have to address preferences. And I know a lot of people kind of gloss over this and, yeah, just offer them a magazine, they'll be fine. But it really goes way deeper than that. We want to make sure that this patient is completely set to buy us a little bit of time to go devote all of our attention to another patient. So addressing preferences is a whole lot more important than you think it is. Not just for the test, but for your workflow. We want to make sure the patient is covered at the end of the skill, either with a sheet or with clothing. I don't want to see their knobby knees. Get them covered. Evaluators don't want to see those knobby knees either. And we're going to open the privacy curtain and give the patient the call light. Now, we don't care how you do this. However you do these steps, knock yourself out. But they need to be clean and safe environment. They need to be comfortable. They need to be covered. They need their call light, and we need to open the privacy curtain. We also want to make sure they're comfortable. Get all of that done. I don't care how you do it. Don't care. Mix it up. I usually have a way that I do that every single time, kind of like a little script that I follow, so I don't miss anything. But once you get all of that done, then you're going to go clean your hands. We got to get rid of those cooties. Once we've cleaned our hands, should we come back to the patient? No, because we have clean hands. If we come back to the patient and touch stuff, what happened? What did we do? Yeah, we cootied back up. So once you wash your hands, you're done with that patient. That hand washing is you're done with the patient. If you have to return to the patient, if you wash your hands and you look over and you realize that she doesn't have her call light, it's at the top of her bed. If I walk over here and see she does not have her call light and I touch that call light to give it to her, what do I need to do? Wash your hands again. Once you do all of those things, then if we have to document, that's when we would do it, after we've washed our hands. But our big neon sign rule here is that we have to end skill with clean hands. So if you document, you have to wash your hands again so that we're ending the skill with clean hands. Good? Questions? All right, let's review the skills that we've learned so far. So we just reviewed the principles. And I want you to remember, this is the beginning of class 3 that we've done all of this review. You'll get another one in class 4, and you'll get one more in class 5. So class 4 and 5, I'm going to go through these principles again. Remember, it's always the first part of the live stream. So if you need a review before you go test, that's where you go. Okay. All right, we learned how to take a pulse. Pulse rate is an indirect measurement of how many times the heart beat. So when the heart beats, it pushes out a wave of blood. We're going to press down an artery and count those waves, right? But when we do that, we don't want that arm kind of hanging out in midair, because that arm, if it's not supported, is going to require more blood flow because those muscles are having to tense to keep that arm straight. So we want the arm supported on the bed, elbow on the bed or a table or something. That's going to be important with blood pressure today too. We never want that arm, just kind of hanging out in midair. Pulse rates are always reported over 1 minute. If you tell me somebody's got a pulse rate of 62, that means their heart beats 62 times a minute. If you tell me somebody has a pulse rate of 47, that means their heart beat 47 times in that minute. It doesn't mean we have to count for a whole minute every time. It means it's reported over a minute. So if we're not going to count for a whole minute, how do we do this? Well, we count for 15 seconds. And if you look at the clock, there's 4 15-second segments in a minute. So if we count for one segment, 15 seconds, we're going to multiply that by 4 to get our full minute. So you don't want to come to me and say somebody's got a pulse rate of 15. Because if you tell me they got a pulse rate of 15, they're dead. Close to it. If you counted for 15 seconds and got 15, don't tell me you got 15. You would have to multiply 15 by 4 to get the pulse rate. Make sense? Good? You don't always have to count for the full minute. There are shortcuts we can take. How do we know which way is right for this patient? Counting for 15 seconds and multiplying that by 4, or counting for the full minute? How do we know? The care plan. That's right. We're going to follow the care plan. Normal pulse rate is between 60 and 100. That's our normal. And you do have to know normal. You will have one test question on the written test that's going to give you some vital signs and ask which one do you need to report right now. So you have to be able to look at a bunch of vital signs, just a bunch of numbers, and know which ones aren't right so you can report it. We're going to use our fingertips, not the flat area of our fingers. We don't use our thumb to take a pulse. Anybody remember why? Has a pulse itself, an artery, that's right. Radial pulse is located on the thumb side at the top of the wrist, way up here, and you want to be at the lines, not down here. You need to be at the lines, way up here. We're going to say start and stop when we count. And in Florida, we're going to count with 2 evaluators. This skill requires documentation. I just finished this video, the new one. And it's, I put it up on YouTube, but it's marked private, so nobody can actually see it yet. But the way that I did this is really, really cool, because with the new video, you can actually count the pulse rate with me. So on the screen, I'm showing what I'm feeling underneath my fingers so you can count along. I've also got all of those checkpoints at the bottom of the screen so you can see as I'm doing an action which checkpoint is getting marked off. So these new videos, they're coming out really, really good. And I think that they're going to be a real benefit to you guys. But later this week, you'll actually see this new one on our YouTube channel. Go take a look at it to kind of see how each one of these things is going to correspond to a checkpoint. We also learned how to dress a resident. So we always ask patients what they want to wear. If it doesn't match, we can suggest an alternative, but we're always going to honor their wishes. We're going to get the clothing before we undress them, limit the amount of time they're undressed. We're going to lift from below, supporting all joints underneath. We're going to undress the strong arm first, dress weak arm first, being careful not to overextend or force movement. We'll adjust the clothing for neatness and appearance. Dirty items go in the hamper, never on the floor, ever, never on the floor. And the call light will go in the stronger hand. We also learned how to do a range of motion. Remember, CNAs do exercises to retain function, not regain. We're going to lift extremities from below with a flat palm. You're starting to see that that's going to play a role in every skill that requires us to lift. We're going to have two, can you take that down for just 1 second? 2 points of support near the joints. We'll move slowly and smoothly, returning all the way to the start position. Flexion extension is up, down. Abduction, adduction is side to side. Rotation is around. We do whatever the care plan tells us to do, which exercises, which body part, and how many repetitions. All right, go ahead and throw that up. Why should I open the privacy curtain first without washing my hands after touching the curtain and giving the patient the call light with my dirty hands? That's a great question, Olivier. So the call light is dirty. Absolutely. Patients in bed scratch what itches and then use call light to tell you about it. Call light's dirty. Curtain, also dirty. We've learned that. Everybody touches the curtain. But remember that this is the patient's environment. Their cooties. Their cooties. What we're trying to do is prevent other people's cooties here, and we're trying to prevent us taking their cooties out. So it doesn't really matter, honestly, that you're touching the call light and the curtain. What matters is that you're washing your hands after you touch those two things to prevent those cooties from being taken elsewhere. My own personal opinion is I open the curtain after I get done with everything with the patient. But the test isn't really testing you on that. As long as the curtain gets open somewhere in the closing, they're good. They're not grading you on infection control that strongly. I hope that helps. Yes. Okay. All right. So here's a question. You are counting your own self pulse. No. You are going to count the pulse of the patient. So we have to find the patient's pulse at the wrist, 2 fingers, not your thumb. And you're going to count how many thumps you feel under your fingers for 1 full minute. It's not about you. It's not about counting your pulse. It's about counting the patient's.
I believe that's what she was trying to state by saying you are counting your own self pulse. I think that may have been what she wasn't a question. I think she was clarifying by saying if you use your thumb, you end up counting.
Oh, okay. Got it. Got it. You ask a question about, well, you should not use your thumb. So I'm asking, okay, yes, yeah, got it, got it. Okay, yes, you're right. You're right. That's why we shouldn't use our thumb. Yes, good answer.
My apologies.
Got it. Nope, that's good. All right, so this is what we've learned so far. Out of everything we're going to learn, we only have 4 left to learn. So not bad for your first week. You've gotten quite a bit done. Are you guys good with this? Can I move on? Because we're going to build on what we've learned. All right, so let's start with our first washing skill. This is on page 116 of your book. So if you're looking at this, page 116, so if you're looking down here, you can see all of the principles involved in this skill. They're all spelled out for you here as well, so the long form. So we know skill rules, we know the opening, we know glove rules, and we know the barrier. Done. We know linen rules, and we know the closing. So there's a couple things we have to learn in order to be able to do this skill. So we're going to add a couple of new principles in today. This is the short form of the skill. This is the video. Down here tells you test specific information. Someone with your level of experience should be able to do hand and nail care within 11 minutes. Guys, all you're doing is washing, rinsing, drying one hand, cleaning the nails, filing the rough edges, and putting lotion on one hand. That's it. They give you 11 minutes to do that. That's like way more time than you actually need. Don't rush your way through this one. Okay? This is going to be done on a live testing student. That could be you. You may be a patient for this skill. For the test, this patient will be sitting in a chair at the beginning of the skill. Documentation is not required. So these are the principles that we need to learn in order to be able to do this skill. And we're going to start with washing rules. Washing rules is going to be on page 112. And you can see that we have 5 skills that are going to require washing. So a quarter of the skills that we learn to do have to do with washing. A quarter of our skills is washing. So these steps are going to be pretty important. I have a video on this you can watch. And the notes for everything I'm going to tell you start on page 113. So the first principle in washing rules is that basins are no soap zones. And in order to understand this, you got to think about the way you bathe. Now, unfortunately, the way you bathe is very routine to you. You're on autopilot. You step into the shower, you're usually thinking about a million other things or jamming out to music. You're not thinking about the mechanics of what you're doing. You're not thinking about, I have to put soap on the puff or the washcloth, or what. I've got to scrub. You're not thinking about the steps. You're just doing it because you've done it all of your life. But I've got to bring your attention to this because the way we bathe ourselves is very similar to the way we bathe other people. So I've got to make you aware of these steps. So when we bathe, whatever we wash, we rinse. We wouldn't get all soaped up and then step out of the shower with soap all over you, all sudsed up. I mean, nobody would do that. You would always rinse off before you get out of the shower. That's just routine. That's just what you do. The problem is that on the test, lots and lots and lots of people forget to rinse because you're doing it on somebody else. So rinsing is a very important part of what we do, but it's really easy to overlook. So in your mind, as you're doing this, I want you to think to yourself, whatever I wash, I rinse. Whatever I rinse, I dry. Now, I know that's super simple, and I know you're thinking in your mind, I would never forget to rinse. And it's amazing how many times this happens. I'll give you an example of this. When I was retaping these videos that I'm working on now, about 2 months ago, I did an entire skill, completely forgot to rinse. Now, if I can forget, and I'm the one teaching, and I do this for a living, is it possible that you will forget during the test? So I want you to remember, whatever I wash, I rinse. Whatever I rinse, I dry. And if you say that to yourself as you do the skill, you won't forget that step. I'll explain to you why that's important in just a second. So whatever I wash, I rinse. Whatever I rinse, I dry. And since we have to rinse, that means we need clean water for rinsing. If we add soap to that basin, we don't have clean water for rinsing. So we never add soap directly to the water in our basin. Basins are no soap zones. Instead, we're going to get our washcloth wet and add soap to the washcloth. Good?
You use 2 washcloths, one to rinse or wash with, and then one to rinse with.
Right. Well, that's exactly what we're going to do. 2 washcloths, one to wash and one to rinse. But we can't put soap in the basin because if you do, then your rinsing washcloth is all soapy. But yes, we're going to use 1 washcloth to wash and 1 to rinse. So to get water, any bathing skill requires water in this basin. We have to think about how to get that water. So I want you to remember the opening. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do hand and nail care. Is that okay? Close curtain, wash hands, get clean supplies. So now we're ready to get water in our basin. We've already washed our hands and all we've touched are clean supplies. So should I touch that faucet with my clean hands to turn it on to get water? What do you guys think? No. So if our hands are clean and we need water, we can't use those clean hands to touch the faucet to get the water. That means that we need a barrier between our clean hands and that faucet. So anytime we get water for a patient to use, remember the order this has to be done in. Anytime we're getting water, we have to have clean hands, but we can't touch the faucet with clean hands, so we're going to use a barrier. Now, I had an instructor probably 2 weeks ago, I think it was, who called me and said, and I have instructors all over the country that call all the time. But she called me and she said, hey, listen, we were watching one of your videos and the students asked a question and I want to run it by you. The students asked, well, why can't we just use a paper towel to turn the faucet on all the time? That way I don't have to really think about it. And I said, that's fine. You can absolutely do that. You can, anytime you touch faucet, use a paper towel to turn it on. That's fine. There's no problem with that. Except for the waste. That's a whole lot of paper towels. Think about every time you turn that faucet on. We have to have one to turn the faucet off, yes. But if our hands are dirty and the faucet's dirty, there's really no need for a paper towel. It's actually better for you to understand clean and dirty than it is to give you a rule to follow without thinking. Does that make sense? Okay. When we start following rules without thinking, that's when we end up in trouble because we're not thinking. So we're going to use a paper towel to turn that faucet on. We're going to check the water with the inside of our wrist, this part of the wrist. That water should feel warm, not hot, not cold, just warm. But it's not just enough for us to check it. Your patient has to check it as well. So anytime you get water for patients to bathe, we check it. We ask them to check it. Now, let me explain why. This is the most important step in hand and nail care. Asking the patient to check the water temperature. The most important step in hand and nail care. But in order to understand that, you've got to understand why. And this is a change of aging. Remember I said chapter 4 that you're going to read tonight is all about changes that happen as we age. This is one of those. When we are young, we have layers to our skin. And when we are young, those layers are fat and plump and in good shape, and they're awesome. They're fantastic. But as we age, those layers start to shrink. You can actually see how those layers are starting to shrink. Have you ever seen a really old person's arm? it's like veins right under the skin, and they're thick, and they kind of go in all, it looks like a roadway, right? Or like a map. So how do we go from, if you look at your arms don't do that. How do we go from arms that don't look like that to arms that do? This is part of the process of aging. This layer of fat here serves a very important purpose. And this is what's really going to shrink as we age. That's why you can actually see the veins on an old person's arm, because we've lost that layer of fat. Now, what does that layer of fat do, and why do we care? Well, that layer of fat actually acts as a wetsuit. So, in order to understand this is a little bit of a complex topic, and I'm really going to try to fifth grade it down for you. So this is a very simplified version of how this actually happens. Remember that. Very simplified version. But anybody know what normal body temperature is? Like, what is your normal body temperature? Close. 98.6. And it's actually a range, 97.6 to 99.6. Somewhere in there is where your body lives comfortably. What do you think room temperature is for us to be comfortable? Anybody know? What do you set your thermostat at to be comfortable?
68, 70.
Okay. So let's use, I like easy numbers. I like easy. So let's say that a body is about 98 degrees, right? Because that's in the range. And room temperature, let's just put it 72. Okay, so 98 degrees for bodies, 72 for room. Sound fair? Good? Okay. The problem is that room temperature always wins. Always. Always. If you take a pie out of the oven, you baked a pie at 325, took it out of the oven, how would you describe that pie as soon as it comes out of the oven? Hot, right? It's 325 degrees. It's hot. You put that hot pie on top of your stove and you leave it there in room temperature for a couple hours. What happens to that pie? Cools down, and it actually cools down to room temperature. Room temperature always wins. Now, pie goes well with ice cream. So let's open the freezer and get our ice cream out. And the ice cream is about 10 degrees, right? It's frozen. You take that ice cream out and it's cold. Put it on the counter for a couple hours. What happens to the ice cream? It melts. It warms up to room temperature. So room temperature always wins. Always. Doesn't matter if you're starting out hot or cold, room temperature always wins. Well, why do we care? Because if our bodies have to be around 98 degrees and room temperature always wins, that's a conflict. That means that in order for your body to stay at 98 degrees, your body has to do something actively to keep you at that temperature. Have you ever heard the term burning calories? That's why you eat, guys. Yes, you're getting nutrition from it, but you're eating to have something in your body to burn, to create heat, to keep you at 98.6 degrees. That's what your digestive system does. It generates heat. Make sense? Good? So when we wear that wetsuit, that layer of fat, that actually keeps our body from having to work quite so hard, because the heat that our body is generating stays inside. It doesn't radiate out. And all the external temperatures, all this room air stuff, doesn't really get in that effectively because there's a layer of protection between room temperature and my furnace. Make sense? So that layer of fat's actually really, really important to help maintain human body temperature. And without it, our system has to work so much harder because heat that we do create radiates away. and outside temperatures can affect us much more violently. So when you look at the skin, right, the skin is a barrier. Remember that? The skin is a barrier, kind of like a glove. And that skin is there to protect us from all the pathogens out here. Behind that skin layer is that layer of fat to hold in our body heat and block out external temperatures. And below that are our blood vessels and muscles. So this is how skin is used in the body. Now, the problem is that if we lose that layer of fat, as we age, that layer of fat goes away. So if we lose that layer of fat, that means that the body heat that we have inside is going to radiate away. It also means that external temperatures are going to be felt differently. Does that make sense? So when I put my wrist underneath the water and it feels warm, when I bring that same water over here to the patient, she is going to interpret that temperature completely different because she does not have that layer of fat that I do. Have you ever walked into an old person's house and you're like, oh my gosh, it's so hot in here. Grandma, turn on the air. This is awful. Yeah, it's like 80, 81 degrees and Gram's just happy. In fact, Gram might even be saying, I'm a little cold. And you're like, you're nuts. It's hot in here. Well, that's because her body doesn't want to work so hard to generate that much heat. So if her environment is warmer, remember, room temperature always wins. If the environment is warmer, her body doesn't have to work as hard. This is also why a lot of times we see older people wearing sweaters and jackets when we're perfectly comfortable without them. But it's also why you'll hear old people in Florida say, yeah, I can't live up north anymore. I can't tolerate the cold. That is a very real thing. And that's why everybody retires to Florida, because of temperature. Make sense? Good. So we have to have the patient check that water temperature every time we get water. That is why this is the most important step in this particular skill. Ask the patient to check the water temperature. That's right. So I'll tell you one of the worst. I get along with pretty much everybody. I'm pretty easygoing. But when you ruffle my feathers, I can be not so nice. I think most of us are like that, right? Well, this is one of the few CNAs that got to see my feathers ruffled. I was sitting at a nurse's station documenting, and it was like a big documentation. I think the patient had an episode or a fall or something, but it was something that I really had to concentrate on for documentation. And I'm hearing a screaming down the hallway. I mean, just screams. So I get up and I run down the hallway thinking, oh my gosh, something is wrong. And I'm trying to trace it down, right? So as I'm going by rooms, I'm listening. Where's the screaming coming from? And I get to the shower room. And the shower room is where the screams were coming from. And all I can think of is, oh no, somebody fell. So I open the door quickly and steam comes billowing out. And I can't see because I got glasses on and my glasses get all fogged up. But I found the screaming. And I walk in, I'm like, what's going on in here? Is everybody okay? And the patient is just yelling. And the CNA is fighting with the patient. So I immediately turned the water off and said, what is going on? Covered the patient up with a bath blanket. What is going on? And the patient was just crying hysterically. It's hot. It's hot. And she was beet red. It's hot. And the CNA was arguing with her. It is not hot. I checked it. It's perfectly okay. You just don't want to be showered. And was just mean to this patient. So I sent that CNA outside. Told her I'd talk to her in a few minutes. And I got the patient cleaned up, dried off, dressed, and back to their room. And then I went out to talk to that CNA. When a patient says something is too hot, believe them. Your job is to believe them. That CNA, all they had to do was make the water cooler. And this whole situation would have been avoided. We are not there to do things to patients. We are there to help patients with things that they would normally do themselves. And you've got to be really, really careful with this, really careful, because it's really easy for you to slip into this mindset when you're out there working, because you're the one doing the work. And it's really easy to start treating adults like children. They are not children. They are adults. And if they could be doing these tasks themselves, they would. They do not want you to be in all of their personal spaces. They would do it themselves, but they can't. So we need to help them, but we need to do it with dignity and by making them a partner, not a prisoner. Does that make sense? Yeah, that situation, 20 years later, still ruffles my feathers. Don't do that to your patients. So the order we do this matters. Whatever we wash, we rinse. Whatever we rinse, we dry. You want to say that in your mind as you do this, because any soap that's left on the skin, this is what it's going to look like when it dries. That causes itchiness. It'll dry out the skin, which can cause cracks. Remember, cracks are doorways that let pathogens in. Good? We got to make sure we rinse well. If the water gets cold or soapy, like if you take a long time to do this skill and you're new, it's going to take you a long time because you're new. That's okay, but pay attention to that water. If it gets cold or soapy, do something about it. Don't ignore it. Nobody wants to be cleaned up with cold water. Dry surfaces should remain dry. This is why we use a barrier on the table, but make sure your barrier is absorbent side up. We need a place to put these washcloths after we use them. We can't put them on the floor. So we're going to put them on the barrier, but we don't want to put them on a table, which would contaminate the table. So this is why we use that barrier. We don't want to get the surface wet. When we put lotion on, we're going to warm up that lotion in our hands. Don't squirt cold lotion onto your patient. Do not do that. Warm the lotion up in your hands. Put it on, and then we're going to wipe off the excess. That way, a lotion doesn't stay on top of the skin and cause a slipping problem. So that's washing rules. All washing is going to be the same way, exactly the same. But if we have a basin with water in it, now we got to know how to clean our basin. And this is the basin cleaning procedure. We're going to use this a lot. We use this on a lot of skills. If you don't get this right now, don't panic. You're going to see this over and over and over and over and over and over and over. But the thing about basin cleaning, this is on page 90, is that all basins are cleaned the same way. All of them. We're not looking for sterile. We are not looking for sterile. We're just looking for clean. When you brush your teeth in the morning, you probably don't whip out the bathroom cleaner and clean that sink every single time you brush your teeth. You probably just rinse out the Big Glob's toothpaste. And chances are you're not the only one that uses that sink in your house. Other people use it too. So we're looking for clean, just like we do at home. Clean, not sterile. So set your expectations here. That means when we're cleaning basins, we're just looking for clean. We're going to rinse it out just like we do at home. We're going to dry it off and put it away. we do not have to disinfect. This is not used by other people. Basins are single patient use. When you go into the hospital, you get an admission kit. In that admission kit are all the basins you're going to need while you're staying in that hospital, and those are just for you. Your roommate does not get to use them. They are just for you. So rinsing, drying, and storing, perfectly okay. But there are some situations where we do have to disinfect. If our patient is on chemotherapy, your basins have to be disinfected because we are obliterating their immune system. We're killing it on purpose. Every single solitary infection control cell you have in your body has to die for us to replenish. That's what chemotherapy does. So if you don't have any immune cells in your body, we don't want you to be introduced to anything that could make you sick. You don't have a way to fight it off. So if your patient is undergoing chemotherapy, those basins have to be disinfected. If your patient has HIV or other immune deficiencies, the basin has to be disinfected. If your patient has an active blood-borne pathogen, then your basins have to be disinfected. How would I, as a CNA, know when a basin needs to be disinfected? The care plan. We have a process in place for that. The care plan would tell us. For the test, we simply rinse, dry, and store the basin. No disinfection is required. But the process that I'm about to show you is done the same way, whether you disinfect or not, because the process allows for that disinfection step to be added in when it needs to be. Good? Make sense? So this is how basins are cleaned. Page 91 is your notes. We're going to dump the contents of the basin wherever it would normally go. If it's bathing water, put it in the sink. If it's urine or feces or vomit, put it in the toilet, wherever it normally goes. Once you have the basin emptied, then we're going to rinse it with rinse water from the sink. We're going to put that rinse water wherever the contents went. So if it's just bathing water, I'm going to rinse the basin and dump the bathing water in the sink. If it's urine, I'm going to rinse the basin and dump the rinse water in the toilet. Good? Make sense? Remember, the basins are only used by that one patient. They only need to be rinsed after each use. But once we rinse it, we're going to put it down in the sink. Because if we do need to disinfect it, I can't be holding that basin with dirty hands or dirty gloves while I'm spraying it. You can't hold it with something dirty and spray it and get disinfected. Does that make sense? So we're going to rinse it, dump it, set it down, and then spray it. That way our dirty glove isn't holding that basin while we're spraying it. So once we set it down and spray it, now it's disinfected. We can't pick it up with dirty hands or dirty gloves. So we're going to use a paper towel between our gloves or our hands and the basin to pick it up. And then we'll use a paper towel to dry the inside, paper towel to dry the outside. And then we have to put this basin away in the drawer. I can't touch that drawer with dirty hands or dirty gloves. So we'll use a paper towel to put our basin away. Does that make sense? So we're going to dump it, rinse it, dump it, set it down, spray it if our care plan tells us to. Pick it up with a paper towel to dry the inside, paper towel to dry the outside, and one more for the drawer. That's basin cleaning. And you're going to see this a lot in this class. So if you didn't get it this time, it's okay. You'll see it again. Everything is cleaned the same way, whether it's a bath basin, a bedpan, an emesis basin, a graduate container, it's all cleaned the same way. And then these are our steps for basin cleaning. Good? So now we know all the principles we need to know to do hand and nail care. So let's learn about hand and nail care itself. Remember, every skill starts with a care plan. We're going to read the care plan. It's going to tell us what to do for that patient. And then we'll do our opening. Every opening starts with a knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? I'm here to do hand and nail care. Is that okay? Let me close your curtain, wash my hands, get my supplies, and I'll be right back. We'll get a barrier. We'll go get our supplies, put them on the barrier. We'll go get water using a paper towel to turn the faucet on. I'll check it. My patient will check it. And then we can do hand care. Good? Good. So hand care is nothing more than soaking a hand, taking it out, putting on a towel, and washing the hand. Remember, you can't wash it in the basin. We need rinse water. So I'm going to wet the washcloth, put the soap in the washcloth, and wash the hand out here. Once I have the hand washed, I'll put it back in the basin to rinse. Then I'll take it out, put it back on the towel, and dry it. Then I'm going to take an orange stick, which looks like this. The slanted end of the orange stick, which is the part that looks kind of like a scoop, not the pointy end. This part looks like a scoop. It goes underneath the edge of the nail. We're going to circle it around to get any debris that's underneath that nail. So under the nail, circle it around. But now I got gunk on my nail or my orange stick. Do you think I want to put this gunk underneath the next nail? What should I do? Wipe it off on the towel. Yeah, we'll wipe it on the towel. Go to the next nail. Underneath, circle it around. Got gunk, wipe it off. Underneath the nail, circle it around. Got gunk, wipe it off. Underneath the nail, circle it around. Got gunk, wipe it off. Underneath the nail, circle around. Got gunk, wipe it off. Now that we've got our nails clean, we're going to use an emery board to file the nails in one direction, always toward the center. This is important. You guys probably take a nail file to file your nails, and you probably do something like this. Really fast, back and forth to file the nails. You cannot do that with older patients because as we age, our nails get brittle. And when you do this rapid back and forth thing, what that does is it pulls the nail this way and then pulls it this way. And that puts a lot of stress on the middle of the nail. And with brittle nails, that will cause the middle of the nail to literally crack like ladybug wings, and the nail will fall off. And it's horribly painful. So we don't do that with patients. It's one direction toward the center. Once we get that done, then we can apply lotion by warming it up in our hands, putting it on, and wiping off the excess. So, whoops, let me go back here. So here are our test-specific steps going down the side here. We're going to soak the hand in water. Whatever we wash, we rinse. Whatever we rinse, we dry. By the way, wring out your washcloths. No drippy, wet washcloths. Wring them out good before you apply soap. We're going to wash. Whatever we wash, we rinse. Whatever we rinse, we dry. We're going to make sure that the hand is on a towel when we take it out of the basin. We'll clean under the nails with the beveled end of the orange stick. We'll wipe that orange stick off between nails, and then we'll file in one direction toward the center. Always want to make sure you support that wrist and arm at all times when you're moving the hand, and we'll apply lotion last, wiping it off after we apply. Then we'll do our closing. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine? Here's your call light. I'm going to open your privacy curtain. Bed's in low position. Environment is clean. I'm going to go wash my hands, think about my skill, make any corrections, and my skill is done. Good. Okay, let's go ahead and watch this video. Jacob.
Loaded up last time or before.
It's fine.
Hand care.
Mm-hmm. Oh, thank you. every facility is going to handle that differently. That's a great
Hello.
question for an
Hi, Mr.
interview.
Jones. My name is Patty. I'm your CNA today. How are you?
I'm doing great. How about you?
Wonderful. I need to do hand and nail care on one hand. Is that okay?
Yes.
I'm going to close your curtain for privacy. Let me go wash my hands and then I'll gather my supplies.
Okay.
Okay, we're going to start with the barrier. So I'll place a barrier on the table and that will give me a place to set your clean supplies. And then I'm going to gather a basin, soap, and lotion. An orange stick and emery board. Two washcloths and a towel. I'm going to go get some water in the basin.
Okay.
Okay, Mr. Jones, would you like to check the water temperature, make
Yes,
sure it's
ma'am.
okay?
It's
Is
great.
it good?
Yes.
Okay, you can submerge your hand in there if you'd like,
Okay.
and I'll bring that tray a little bit closer to you.
Thank you.
Is that comfortable?
Yeah.
I'm going to place the washcloths in here, and we'll wet one of the washcloths and use it to get your hand wet. Now I'm going to place your hand over here on the towel. Apply soap to the washcloth. And now I'm going to wash all surfaces of your hand, including in between the fingers, in this area between the thumb and the forefinger. We're going to turn your hand over now and wash the palm of your hand. Now we're going to place your hand back in the basin to rinse. Okay, I'm going to bring your hand over here to dry. I'm going to dry between the fingers. And then I'm going to turn your hand over and dry the palm of the hand as well. Okay. Now we'll take the orange stick and I'm going to clean under each nail. Just cleaning the edge. Does that hurt?
No.
Very good. We'll wipe the orange stick on the towel in between each finger. And now I'm going to file any rough edges. So I'll file from the outer edge to the middle, checking each nail for any rough edges. And now we can apply lotion. So I'll get a little lotion, warm it up in my hands, and apply it to all surfaces of your hand. Does that feel good?
Yes.
Very good. Okay. Now we'll wipe off the lotion. Okay. How's that?
Great.
Wonderful. I'm going to place my soiled linens in a dirty linen container and then clean up my workspace. I'll be right back.
Okay.
Okay, on the way, we'll pick up the soap and the lotion and place them in the basin. We'll use the paper towel to open the drawer, place the basin in. These items will get thrown away. Okay, Mr. Jones, are you comfortable?
Yes, ma'am.
Can I offer you a magazine?
No, ma'am.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your call light is right there. Please use it to call me if you have a need. I'm going to open your curtain and wash my hands.
All right, after washing my hands, I'll make any corrections and then tell the evaluator my skill is done. Am I unmuted? Yeah, okay. All right, any questions on hand and nail care? No? Guys, all we're doing is washing one hand and cleaning the nails. This is not a hard skill. The thing about this is that's really kind of important for us to understand. CNAs do not use nail clippers. We don't. Nail clippers are advanced pieces of medical machinery we're not allowed to touch. And I know that sounds weird because you've got them all in your house. You use them regularly. But when we have patients that have different conditions, when you clip nails, especially those that aren't yours, it's very easy to clip the skin next to the nail. For instance, I don't know whether you can see my nail here. You see that? That can happen very easily. And if you have something like diabetes, it can actually prevent that area from healing well. So CNAs don't clip nails. We file them on a regular basis. And as long as you're filing the nails on a regular basis, you never have to clip them. That's what this skill is all about, keeping the nails at a manageable length and smooth. That's all we're doing here. Okay, good. Okay. All right, so we're going to move on to making an occupied bed, which is our next skill. This is on page 141 of your skills book. And if you look at the principles involved down here, they're all spelled out here. We know skill rules. We know the opening. We know glove rules. We know barrier. We know privacy blanket. We know some of linen rules. We're going to get to the last two here. And we know the closing. So scoot and roll, we don't know. And we're just briefly going to touch on that today. We're going to talk about it a little bit more on Wednesday. I have a video for this. Down here is test-specific information. So somebody with your level of experience should be able to make a bed with somebody in it within 14 minutes. I can do it in about 4. 14 minutes, that's way more time than you need. I can make an unoccupied bed in about 2. So if I have a choice, I'd rather make the bed without somebody in it because I can do it a whole lot quicker. So if I walk by a room and there's nobody in the bed, that's a great time to change the sheets. So if the patient is at a meal, at a therapy session, having a test done, anytime you walk by a bed and it doesn't have a body in it, you should think to yourself, do those sheets need to be changed? If so, let me do them now because it will save you time. But it also saves the patient from a lot of excess movement, which can be very tiring. So they give you 14 minutes to do this. This is a live patient skill. So one of you guys might actually be the body in the bed while the sheets are being changed. This is a bed skill. Charting is not required. And we're going to go over our last 2 linen rules. Remember, we've already gone over these. We learned that linens can't touch your uniform. We learned you have to have clean hands to get your linens. And we've learned that you don't snap or shake your linens. We also learned that everything that you don't use has to be discarded. So let's talk about these 2 here. And that will finish up linen rules for us. And this is clean rolls toward me, dirty rolls away. And let me explain what that means. Let me grab a couple of washcloths. Okay. So let's say that we have a sheet on our bed. Can everybody see this? And we have a body on the sheet. Good? With me? Okay, so our principle is clean rolls toward me, dirty rolls away. So this is the dirty sheet because the patient is currently laying on it. Guys, you can't do this, you can't make this sterile. A lot of people are going to try to really go big on infection control here. I want you to remember that throughout this entire skill, this body is still in the bed. Whatever this body touches gets contaminated. So this body is on that sheet. As soon as this sheet gets put on the bed, this body is going to be on this sheet. This body is on the pillowcase. So we're not trying to make this sterile. We're just trying to get clean sheets on the bed. We know it's going to be contaminated at the second we put it on. But we do want to try to minimize that contamination whenever possible, especially if the sheets are wet. So let me show you how we're going to do this. So when we have a patient that's laying on their back in the middle of the bed, they're taking up quite a bit of the bed. If we get them on their side, they take up a little less of the bed, a little smaller footprint. So we want the patient on their side. Okay, good. Then I'm going to take this dirty sheet and I'm going to roll it toward the patient. And when I do that, the underside of the sheet is what's facing up. The part that was touching the mattress, not the part that was touching the patient. And I'm going to tuck that underneath the patient. Then I'm going to take the clean sheet, unfold it, and clean rolls toward me. So I'll roll the clean sheet toward me. And again, it's the underside of the sheet that's facing up. So I'm going to tuck this roll under this roll. Good. So the only thing that's touching are the undersides of the sheet. Now, if this dirty one is wet, I'm going to take a Chucks and I'm going to wrap it around that roll. Remember, Chucks are waterproof. So if I've got a Chucks wrapped around that roll, the wet isn't going to get on the new sheet. Then, once I have both rolls underneath the patient, I'm going to go around to the other side of the bed, have the patient roll on their side facing the other way, and then I can take that sheet off and unroll that one. Patient back on their back in the middle of the bed. Then we put it on a top sheet and a pillowcase. Easy. Good. Okay, the trick here, and it is a trick, when you have the patient on their back, or I'm sorry, on their side facing away from you, and you take that dirty sheet and you roll it toward the patient and you tuck it under them, you have to tuck it under the patient, as far under the patient as you can. Now, I've got a bare mattress here. I don't want my patient laying on a bare mattress. But you've got to get this sheet tucked under the patient as far as you can. That way, when we put the new sheet on, and that one goes under, and the patient rolls, this sheet is able to just be taken out very easily. If you don't tuck that sheet under the patient enough, you're going to have to really tug on it to try to get it out from under the patient. And that can bruise or tear skin. So the key to this skill is to make sure that your rolls go under the patient as far as you can. Now, this is a live patient skill. You guys may be the patient for this skill. You are fully clothed. You're going to keep all of your clothes on. You're holding on to your body fluids like a champ. So there is no exposure to body fluids, personal skin or non-intact skin during the test. Do you need gloves? No, no exposure. But if I'm in a clinical setting and I got this patient here and she's not wearing undergarments, all she's got on is a hospital gown, and I've got to tuck stuff underneath her, I'm going to touch her butt. Should I have gloves on? Absolutely. If I've got an incontinent patient, do I need gloves? Absolutely. So remember that it's not based on the skill, it's based on the patient. Good? Make sense? Tess is going to make this super easy for you. Everybody stays fully clothed, please. Don't take your clothes off during the test. So they will make this a little bit easier for you. So remember that clean rolls toward me, dirty rolls away. The other principle we have to learn here is that we can't let anything touch the floor. And this is a little bit harder than you think it might be. We don't let anything touch the floor. Not clean, not dirty, nothing touches the floor. Now, when I make my bed at home, you probably do the same thing. When I take the sheets off my bed at home, they go on the floor. Then I put the new sheets on and I take the old sheets and carry them to the laundry room and I throw them in the washer. And I don't think anything of that because it's my house. But if I take these sheets in a clinical setting and put them on the floor, that means that this person's pathogens are now on the floor where other people are going to walk through them. That's not a good practice. Now, the problem here, and it is a problem, is that we don't have hampers in the patient's rooms. We don't keep dirty stuff in a clean environment. So there's nowhere to put this sheet that you just took off the bed. You can't throw it on the floor, and there's no hamper in the room. So that becomes a problem. For the test, they will actually have a hamper in the room or a laundry basket at the foot of the bed. They're going to make this super easy for you. So for the test, you're going to use whatever it is they give you. It'll be right there. Throw your sheets in there. Don't throw them on the floor. But in a clinical setting, we have to look at how we're going to handle this because there are no hampers in the room. In a lot of cases, the hamper is going to be something that looks like this, and it's usually out in the hallway. Well, taking that sheet out to the hallway to put it in the hamper, coming back in and finishing the bed, that's a lot of time. So most people aren't going to do that. And remember, anytime you leave the room, you're supposed to wash your hands. So that becomes problematic. Good? Make sense? So we got to have another way of handling this. Well, if you put a chucks on the floor, you can put the sheets on the chucks. We can't put the sheets on the floor, but we can put them on a chucks on the floor. Good? Makes sense? But what most people do, in most settings, your policies and procedures are going to tell you to do, is to go get a soiled linen bag. These bags, we open them up, we put them on the floor, and your linens go directly in the bag. Now, you guys know what Tide Pods are? Lunch. So these bags are the original Tide Pods. These have been around for like 25 years, like way before Tide Pods ever came out. And what I mean by that is the bag itself is water soluble. It breaks down in water, and it contains the soap that's going to be used in laundry. So when you put stuff in this bag, anything stamped with a soiled linen, when you put stuff in that bag, that whole bag is going in the washer. Nobody's going to take these sheets out and shake them out to make sure there's no hearing aids or dentures or pens or cell phones or earrings or anything else in these sheets. The whole bag and everything in the bag goes into the washer. So that means it's your responsibility when you're changing these sheets to make sure that no foreign objects are in the sheets when we take them off the bed. So we're going to go get the soiled linen bag before we get started, and we can put that on the floor, and then your linens go in the bag. Good? Make sense? So units in an acute care setting, like a rehab or a hospital, and most nursing homes too, are going to have a special room called soil utility. They also have another room called clean utility. So soil utility, the only thing that ever goes in there is dirty stuff. If it's dirty, it goes there. We don't take clean stuff into soil utility rooms, ever. We also have clean utility rooms, which is where your clean items are going to be. And we don't take dirty items into clean utility. So remember that these two rooms, we have to be very careful when we go in that we're only taking the right things into the rooms and the right things out of the rooms. Okay? So remember, we've learned don't store items in a patient's room. We either use it or we lose it. This is a principle that is part of linen rules. So the last principle that we have to learn today is scoot and roll. Because if you remember this guy here, this little guy, we have to have him roll so we can change that sheet. So if I have him roll, just plain roll, he'll probably be near the edge of the bed. Do you think that's safe? Okay. So that's why we have to learn scoot and roll. This is going to be located, the notes for this are located on, oh, it doesn't say. Hold on. 120 of your book. We're going to get into this a little bit more in detail on Wednesday. So I'm just going to kind of touch on these topics quickly. But let's talk about side rails. A lot of people will use side rails when they're changing sheets for safety. And they think that side rails will keep the patient from falling out of bed, and they actually don't. Side rails fail at an alarming rate. When you put pressure up against that side rail, it can absolutely fail. And now you're adding metal into a fall, which increases the risk of injury. So we don't rely on side rails for safety. And there's a lot of problems with side rails. I mean, a tremendous amount of problems. And we're going to talk about them in detail on Wednesday. Tremendous amount of problems with side rails. And I've got to get your mindset right before you ever get into a clinical space with side rails. Now, those of you who have been in healthcare years ago, we used to use side rails for everything. You weren't allowed to leave a patient unless the side rails were up. That has changed. We do not use side rails for safety. Anything that restricts a patient's movement is called a restraint. It's that simple. Anything that restricts a patient's movement is called a restraint. And if you remember me saying earlier today, we cannot treat adults like children. So this becomes a problem. We don't need side rails to keep our patients safe, though. If I turn her over in bed, okay, she's in the middle of the bed, right? If I roll her, where's she at? On the edge. If I let go, what's going to happen? She's going to fall. Do you think she's comfortable? Are you comfortable? Okay. So we can't just roll a patient onto their side. That doesn't work. Even with side rails there, that's going to put the patient right up next to the side rail. That's not going to be comfortable for them. So if we're going to have to turn a patient onto their side, we're going to do what you guys do. Jacob, can you take her out of the bed, please? Put her in that corner. Yeah, thank you.
Look like some broken limbs.
Yeah, thank you. All right, let me have a volunteer. I want to show you guys something. Sure. Okay, can I get you to lay on your back in bed for me? Shoes on, that's fine. Just lay on your back in the bed. It's a very comfy mattress. Feel free to take a nap. Okay, so she knows she's not going to be in this bed very long. So I kind of expected her to lay kind of on the edge because she knows she's not going to be there very long. She didn't do that. Where did she put herself? Why? Why did she put herself in the middle of the bed? Anybody know? That's right. That's because her mind knows that in the middle of the bed is safe. And regardless of how long she's going to be there, her body is going to position itself in the middle of the bed for safety. I didn't tell her to do that, did I? She did it automatically. Now, can I have you roll onto your right side so that you're facing that TV? Okay. So she rolled, but then she did something kind of funny. Did you guys notice what she did? Okay, yeah, and she probably wasn't even aware of it. She subconsciously scooted herself back. Come back onto your back, please. Okay, reposition. Okay, if you were to roll at home, if you were just going to turn on your side, how would you do it? If you're going to turn on your side.
At home,
Yeah.
same way.
That close to the edge?
Yeah, I do. I don't know why.
Okay.
Yeah.
Most people,
And then move over.
yeah, that's exactly it. So most people will shift so that they're on their side, but in the middle of the bed. And that's because our minds feel that we're safest in the middle of the bed. And your body will do this automatically without you even being aware of it. Okay. This is why you can go to sleep at night, toss and turn, and wake up and you're still in bed. Because even though you're sound asleep and you're moving around, your brain knows the space you have to work with, and it will keep you safely in the middle of that space. Thank you. Go ahead and have a seat. So, if we are going to turn a patient, we have to take a page out of that book. If we're going to turn a patient, we're not just simply going to roll them. We want them to be in the middle of the bed after the turn. So to do that, we're going to scoot our patient toward us and roll them on their side facing away from us so that they're in the middle of the bed after the turn. Now, this is why we can't rely on side rails to keep our patients safe. Side rails have a very high rate of injury and death. Patients, just because there's side rails there, are not going to stay in bed. Just because you want somebody to do something, they're not going to do it. In fact, there are some people like me, when you tell me to do something, I'm going to intentionally not do it because who are you to tell me what to do? So if we have side rails up and your patient's trying to get out of bed, what we've created is a barrier to overcome, which increases their risk of likelihood. This happens way more than you think it would. This is called entrapment, and it will absolutely strangle a patient. It happens daily in the United States. So we can't rely on side rails to keep our patients safe. And in reality, we don't really need them. If you scoot the patient towards you and then roll them away from you, they're on their side in the middle of the bed. Now, there's something called a half rail or positioning rail. These are not side rails. It only becomes a side rail if the bottom one goes up. These can be used by patients to reposition in bed, but they don't restrict where the patient gets out of bed. I want you to think about this for a second from the patient's point of view. Let's say that you're put in bed and you're told, don't get up. Don't get out of bed. You're dizzy, you're weak, you're injured, you're on medication, whatever. Don't get out of bed. But eventually you're going to have to pee. So you hit the call light and you wait and you wait and you wait and nobody comes. So you hit the call light again and nobody comes. Eventually, it's going to get to a point that you have two choices. You either pee your bed or you try to get out on your own? Which one do you think you're going to do? Absolutely. Adults are not going to willingly pee their bed because nobody's coming to help them. They will try to get out of bed. Now, what happens 9 times out of 10 is a healthcare worker is going to come in and yell at them for getting up. Should we be yelling at them for doing what they would do normally? No, absolutely not. This is not your patient's fault. Whose fault is it that they're trying to get out of bed? That's right. Why? Because we did not answer that call light. That is absolutely correct. That fall is on you, not the patient. And yet healthcare workers all day, all over the country will yell at a patient 100 times out of 100. I told you not to get up. I called you. You didn't come. What's even worse is, and we're going to learn about this in week 3, what's even worse is CNAs will put adult briefs, we don't call them diapers, adult briefs on a continent patient and say, just go. That's horrible. That would be like me handing all of you adult briefs and saying, toilet's out of order today, just pee. You're not going to do it. You're walking out that door. And I'm getting a no-star review. It violates your rights as a human. Don't do that. Do you see how important these concepts are? So this is the type of stuff you're going to see on the exam. In fact, there might be a question that says, you're caring for a patient that has a side rail order, and the patient is found on the floor next to the bed. The patient says they had to pee and no one answered the call light. What do you do? A, help the patient back in bed. B, help the patient to the bathroom. C, yell at the patient for trying to get up on their own. Or D, notify the nurse. Yeah. You may have a test question like that on the SAY exam. It's horrible. We can do better than that. We can do better. Number one reason that side rails are used, though, and I love this, I was this nurse for years. I was this nurse. Well, my patient's weak. I don't want them up walking around because they're weak. And if they're weak, they can fall. I don't want that. Until somewhere along the line, somebody said, okay, so if you put them in bed, put the side rails up, what did that do to improve their weakness? Oh, so wait a minute. You're telling me that the side rails were for me, not the patient. Those side rails did nothing to improve the patient outcomes. And once that was brought to my attention during this whole changeover, I became team no side rails. Best thing to do for this patient is to make sure that we're in that room often, helping them to the bathroom, helping them to meals, getting them out of bed and into the chair, because those are all the things that are going to help improve the patient's situation and prevent the falls. So win-win. Side rails are for you, not the patient. Good? So in order to make this work, the patient must be in the middle of the bed at all times, not on the edge. So if they're on their back, they need to be in the middle of the bed. If they're on their side, they need to be in the middle of the bed. The middle of the bed is a safe zone. So if we're going to turn the patient onto their side to keep them from being on near the edge of the bed, we're going to ask them to scoot toward us, and then we'll roll them on their side so they're in the middle of the bed after the roll. Good? Now, how do you have them scoot? Well, if your patient can do it on their own, just ask them, scoot toward me. If they can't, we can move them in segments. We can use a draw sheet to move them or a slide sheet. We've got a lot of tools at our disposal, but for the test, they can move on their own. Just ask them, scoot toward me, roll away. Now, you always want the patient to roll away from you, not toward you. And there's two reasons for this. The first is that most of our weight distribution is along our back. So when you've got somebody laying on their side, gravity is always going to pull them onto their back, not their stomach, their back. And you see this with babies. Put a baby on their side, they'll roll onto their back. Weight distribution, gravity. So if I turn a patient toward me and gravity is trying to pull them in the opposite direction, it's very hard for me to stop that roll. It's happening way over here. If you turn a patient away from you and they start to roll, you're right there. You can stop that roll. Super easy. Weight distribution. Always turn a patient facing away from you. But the other reason for this, no easy way to say this, you never have a patient facing eye level with your crotch. When you turn a patient towards you, that's exactly what you're doing. And if your patient's been the victim of a sexual assault at any point in their life, this can be a triggering event. Always turn a patient away from you. Make sense? All right, so let's talk about bed position. So beds have a couple of different ways of being adjusted. There's head of the bed. Make the head of the bed go up. There's foot of the bed goes up. And then there's the whole bed up, whole bed down. For this skill, when you're making an occupied bed, this bed's pretty low. For me to make this bed, I'm going to have to lean over a little bit to make this work. That's probably going to put a lot of pressure on my back, and after a little while, my back's going to start to ache. So what I can do is raise the bed up to a comfortable working height. Absolutely okay. In fact, it's probably encouraged so you're not hurting your back. But if I choose to raise that bed to a comfortable working height, what do I have to do at the end of the skill? If you forget, it's an automatic fail. And that's because that patient expects that floor to be right where they left it. If they swing their legs out and that floor is not where they expect it to be, they're going to put their entire body weight down on a surface that doesn't exist. And that's what's going to cause them to fall. Okay? So for the test, you don't have to raise the bed. You can, but you don't have to. All right. So we don't want the patient to lie on the bare mattress. We're going to replace the sheet on one side of the bed at a time. Clean rolls toward me, dirty rolls away. We'll remove the bottom sheet and secure the clean sheet on the mattress, and we're going to smooth out as many wrinkles as we can. Guys, you're not going to get it perfectly straight because there's a body in the bed, but you want it as wrinkle-free as possible. And we're going to learn why on Wednesday, but try to minimize wrinkles. We'll put the top sheet on. We're going to make some hospital corners and then loosen the sheet over the toes. We'll replace the pillowcase with the opening facing away from the door. So this is my door. The opening of the pillowcase faces away from the door. That way, any airborne pathogens that might come in don't get inside the pillowcase where the patient can breathe them in. And we want to limit the time without the pillow. So page 142 gives you your step-by-step instructions, supplies along the bottom. Guys, you have to learn your supplies. There's no way around it. You have to learn your supplies. Flashcards are the best way to do that. So grab some index cards, make supply flashcards. Remember, we do have flashcards already made up if you'd rather go that route, but you have to learn your supplies because I'm not going to tell you, go change the sheets in room 212. You're going to need to take with you a bottom sheet, a top sheet, a privacy blanket, a pillowcase, a barrier for your table. I'm not going to tell you that. I'm just going to say, go change the sheets. I expect you to know what you're going to need for that skill. So you have to learn the supplies. All right. So let's go ahead and watch this video for Make an Occupied Bed. I'm going to show you this video. I'm hoping we can have a little bit of practice time today. I'm not sure. But I'm going to show you this video because it has really good close-ups of that sheet being tucked. If I do this live for you, half of you aren't going to be able to see that sheet. Okay? but we will have some time to practice somewhere in this program, and I'll be happy to show you when we get into practice live. Huh? Yeah. I got it.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
Good, how are you?
Wonderful. I need to change your sheets. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back.
Okay.
We'll start out with a barrier. I'm going to get a top sheet, a bottom sheet, and a pillowcase, and a privacy blanket. Okay, Mr. Jones, I'm going to place this blanket over you. This will help protect your privacy and keep you warm while we do this skill, okay?
Okay.
Okay, I'm going to spread this out. Can you hold that blanket in place?
Yes.
And I'm going to remove the sheet from the bed. We'll place the sheet in dirty linen. Mr. Jones, can I get you to scoot toward me, please? Thank you. And can you roll so that you're on your side facing in that direction? Thank you. I'll remove the two corners of the sheet from this side of the bed. And I'm going to roll the soiled sheet in toward the patient, tightly. I'm going to tuck it up underneath the patient all along the length of his body. Now I'll take the clean sheet, unfold it, spread it out on the mattress, and attach the corners. Now I'll roll the clean sheet toward me. We'll roll it so that it's tight with no wrinkles as we tuck it under the soiled sheet. Okay, Mr. Jones, come on back onto your back, and I need you to scoot to the center of the bed, please. Thank you. Can you scoot toward me, please? And can you roll so that you're laying on your side facing away from me? Thank you. I'll now remove the sheet from the bed that was soiled, wrapping it into a ball. And I'll go place this in dirty linen. Now I'll unroll the clean sheet and secure the corners on the mattress. As I do so, I'll make sure to stretch the sheet so that it's flat and minimize the wrinkles that are underneath the patient. Okay, Mr. Jones, can you come back onto your back, please? And scoot to the middle. Thank you. I'm now going to place the top sheet over you. And I'll remove that bath blanket now. We'll roll it in a ball and place it in dirty linen. Now I'm going to secure the sheet. I'm going to lift the mattress and smooth the sheet down so that it's flat under the mattress on both sides. Now I'll make hospital corners by lifting the top edge of the sheet about a foot from the end of the mattress, straight up. It'll form a triangle. Everything else will get tucked underneath. I'll repeat that on this side. And I'll loosen this over his toes so he has some wiggle room. There, how's that, Mr. Jones?
Perfect, thank you.
Very good. I'm going to remove the pillow from under your head. I'll bring it right back. I'll remove the pillowcase, being careful not to allow it to touch my uniform, and lay the pillow on the overbed table. We'll place the pillowcase in dirty linen. I'll take the clean pillowcase and scrunch it up all the way to the edges. We'll put the tag side in, place the pillowcase on top of the tag side of the pillow, and pull the sides down. I'll now place the pillow under his head with the opening facing away from the door. How is that, Mr. Jones?
Perfect, thank you.
Are you comfortable?
Yes, ma'am.
Here's your call light. If you should need anything at all, please don't hesitate to call. Can I get you something like a magazine?
No, thank you.
Okay, I'm going to open your curtain and wash my hands. The barrier will be thrown away. After washing my hands, I'll think about the steps of my skill, make any corrections, and tell the evaluator my skill is done.
Houdini skill, you know, pretty cool. Any questions on that one?
Do they, for the residents that are bedridden,
Okay, my yeah.
do they still use the, like the chucks under them, the sheet? To where
Draw
you-
sheet. So in your book for this skill, on page 143, you've got
Draw sheet.
and chucks. So what she's asking is there's other things that we put under the patient in addition to a sheet sometimes, like a incontinence pad, like a chucks if they're incontinent, or a draw sheet if we need to be able to move them in bed. Those items are done at the same time as the bottom sheet. So we put the bottom sheet on the bed, but don't roll it yet. Put your draw sheet and your chucks on there and then roll all of that together and put it under the patient. Good? Okay. But yes, that's in your book. You had another question at the beginning of the video. What was it? Do you remember?
Well, before, we used to ask when you were changing a resident's bed, when they're in it, if they're able, we use the rail and asked them, okay, I need you to roll to your side. You can use the rail. And they grab the rail and pull themselves. You don't do that no more.
No. You cannot use side rails without a doctor's order any longer.
Gotcha.
Side rails are considered a restraint, and we don't need them. Just have them scoot towards you and roll to the middle. Patients are going to feel safer in the middle of the bed, but if that side rail fails, what happens to the patient? Yeah.
What happens when, your resident is a large person and they can't physically move themselves? That I know that's what the sheet's for, to pull them. And then you have to have, sometimes you have to have someone else to help you roll them. Okay.
Mhm.
But they're not gonna be able to hold themselves in place. You know what I mean? So you're pulling them backwards
So
and doing it.
I can't give you one answer that's going to cover every scenario that you're going to come up against when you're out there working. So those problems are always solved by the nurse that's in charge of that patient. They're going to write the instructions that they want you to follow on the care plan. So that's really what the care plan is for, is to answer all of those what if questions specific to that particular patient. I can give you an answer to that right now, but that's not going to apply to the very next patient that you see, because that patient may need a different accommodation. So it really, the answer is it depends. If I've got somebody that's 600 pounds and can't tolerate being on their side very well because of respiratory difficulties, because of the weight pressing in, or cardiac abnormalities because of the weight, then it may be better to use a Hoyer lift and to get them out of bed, sitting in a chair while we're changing the sheets. That might be a better option. So I can't give you an answer that's going to satisfy all of the possible scenarios.
Depends on the care plan.
Right. Make sense? Good. All right. Let me change here. So we're going to learn a range of motion today too. Do you remember the range of motion we learned on last Wednesday? Remember the range of motion exercises that we learned? Well, today we're going to learn how to do exercises on the elbow and wrist. Now, all of the principles that we learned last Wednesday are going to apply here. Page 78 tells you that we don't have anything new to learn. Page 79 gives us our step-by-step instructions, as well as our care plan at the top of the page. So if we read the care plan here, it says, provide the following range of motion exercise to the resident's right elbow and right wrist. Flexion extension. Remember, flexion extension was up, down. So the right, that's this arm, elbow, up, down. And the right wrist, up, down. That's it. Tells us to provide 3 repetitions of each exercise, and the resident's not able to help with the exercises. So that's a whole skill. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to do some exercises on your right arm. Is that okay? Close curtain, wash hands. We'll move the arm up and down 3 times, like they're making a muscle. We're going to keep the elbow supported on the bed and move the wrist up and down like they're revving a motorcycle 3 times. And then we'll do our closing. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Environment's clean. Bed's in the low position. Open the curtain. Here's your call light. Go wash my hands. That's the skill. You're going to spend way more time doing the opening and the closing than you are doing the actual skill. So I'll show you this one live if I can get somebody. Oops. Let me go through my slides. Okay, so there's the care plan we just read. Care plan tells us which body part, what exercises, and the number of repetitions. Remember that flexion extension is up, down, abduction, adduction is side to side, and rotation is around. But all we're doing, according to the care plan, is up, down. This skill, the easiest skill there is for the test. I mean, hands down, the easiest skill there is for the test. Where students go wrong with range of motion, and I've seen it a million times, is they start to get fancy they throw in abduction, adduction too, or they decide to do 10 repetitions instead of 3. It's like, you got to follow the care plan. If you get fancy and start showing that you know how to do other things, all you're doing is telling those evaluators that you don't know how to follow the care plan. And that's going to put patients at risk out there, because that means that you're out there going rogue. You're doing whatever you want to do to the patient, not what the care plan tells you to. We're always going to support the joints from below with a flat palm. Move slowly and smoothly, return to the start position. Ask about discomfort throughout the skill. We're going to do our opening and our closing. Now, gloves for this skill is going to depend on the patient. If your patient has any skin openings, any body fluids that you're going to be touching, then yes, you would need gloves. But for the test, you're doing it on another testing student. Chances are you're not going to need gloves because you guys are all holding on to your body fluids pretty well. Good? Questions? All right, so let me get somebody to come lay down in bed. So one of the things that I've got to, that I need you to understand is that hand washing for the test is graded during your first skill. So the very first skill that's on your testing care plan set, remember those yellow papers up here? You'll get one of those. The very first skill, you have to wash your hands at the beginning. You have to wash your hands at the end, and those are graded. After that, the evaluators are going to tell you that you can simulate hand washing, and this is just an effort to cut down on testing time. Remember, they don't want to watch 56 hand washings. Remember we talked about that? So for the test, you will simulate hand washing for skills 2 and 3. I'm going to show you how to simulate hand washing with this demonstration. So I need somebody to come lay down in bed for me. Thank you. Jake, can you adjust the camera a little bit to put the bed in center frame? Perfect. All right, so here we go. This is simulating hand washing. Hi, Ms. Jones. My name is Patty. I'm your CNA today. How are you? Good, how are you? Fantastic. I need to do some exercises on your right elbow and wrist. Is that okay? All right, let me go close your curtain, wash my hands, and I'll be right back. So I'm going to close the privacy curtain. And we have a curtain now. I have clean hands. That's all you have to do. I've washed my hands. All right, Ms. Jones, I'm going to do all the work. All you have to do is let me know if there's any pain or discomfort as we do this, okay? First thing I'm going to do is bring your arm up to your shoulder and back down to the bed like you're making a muscle, and we'll do this 3 times. So we're going to keep the elbow supported on the bed. We're going to go up and all the way back down. That's 1. Up and all the way back down. 2. Okay. Up and all the way back down. Still good? Yep. Okay, so now we're going to work on the wrist. I'm going to have you make a loose fist, and we're going to bend forward and back like you're revving a motorcycle. So forward and back should feel a little stretch. There's 2. Feel okay? And 3. Good? Are you comfortable? Is there anything else I can get for you while I'm here, like a magazine? Okay. Call light is, well, right there. It's kind of stuck. We'll pretend. Call light is right there. If you need anything at all, please let me know. Your environment's clean. Bed is in the low position. She is covered with clothing. Remember I said either dressed or sheet. She's covered. All right, I'm going to go ahead and open your curtain and wash my hands. I've washed my hands. I'm going to think about the steps of my skill, make any corrections, and then tell the evaluator my skill is done. Thank you. Yes. Okay. This one is the first skill.
Maybe they're referencing on why aren't you wearing gloves, or would you wear gloves for this skill?
Okay, so I would wear gloves if I was going to be contacting body fluids, personal skin, or non-intact skin, none of which applied to that specific patient. Remember, gloves are based on the patient, not the skill. All right. There we go. Okay, so any questions on range of motion? Any questions on range of motion? We're going to go ahead and take our break. When you get back from break, we're going to get into blood pressure. So go ahead and go on break. 1:33. right. Okay, so now we're going to move on to the most technical skill that we have to learn. And this is blood pressure. Blood pressure is very technical. There's a lot of parts to it. There's a lot I have to tell you before we can learn how. So kind of bear with me. We are going to practice together at the end of class today. How many of you guys have a blood pressure cuff and stethoscope of your own? Okay. So do you have it with you? Anybody have it with you? Okay. Don't get them out yet. But when it comes to that time and you get your blood pressure cuffs out, it's very important that you not inflate your cuff unless it's wrapped around something. Because if you just, squeeze that bulb and that cuff inflates, there's a bladder inside that has to be able to press against something. If that bladder doesn't have anything to press against, it can throw the calibration off on your cuff. So very, very important that you don't just like pump it up when it's flat. And everybody tries to get ahead of me, so I didn't want to tell you that up front. Okay, so page 56 is going to explain to you a little bit about blood pressure, what it is, what it does. It's the notes from this lecture. But at the top of the screen, you see it says non-tested skills. Blood pressure is not tested on the state exam. You will not have to take a manual blood pressure or an automated blood pressure for the state exam. Not a tested skill. Used to be, but it's not any longer for Prometric. Other states do still require this. You are still required to know how. You're still responsible for the information. It's just not tested during skills, which means you probably will have a couple of questions on the written state exam about blood pressure since they're not testing it through skills. Does that make sense? Okay, so we're going to talk about this graphic right here. This is what you see on that page. It's a little bit bigger. And I have to explain to you what a blood pressure is so it all kind of makes sense to you what we're actually doing here. So on the left side of your chest, you've got a heart. That heart squeezes and it pushes out a wave of blood. That wave pushes the one in front of it. That wave pushes one in front of it. That one pushes one in front of it. We learned this with pulse. Remember, with pulse, we just put our fingers down and felt those waves moving through. That's not what we're going to do with blood pressure. So pulse tells us how many waves. Blood pressure tells us how strong are those waves. Two different measurements. In order to understand what we're doing here, what those numbers mean, we have to look a little bit closer at this. When a wave is moving through that particular part of the artery, there's a lot of pressure inside. In between the waves, when the heart is at rest, less pressure. So here's a visual to help you understand this a little bit better, because this is a little complex, a little confusing. So let's say that I have a hose attached to a faucet outside of my house, big long hose. And I go over to the faucet and I turn it all the way on. Water starts coming out of the hose expands, gets bigger and firmer. I now have pressure inside that hose. If I turn the faucet all the way off, the water goes down to a trickle, the hose gets softer, less pressure inside the hose. When the heart squeezes and pushes out a wave of blood, that's like turning the faucet on. When the heart is resting, the faucet is off. So all the heart is doing is standing at the faucet going on, off, on, off, on, off, on, off, on, off, a million times a day. On, off, on, off, on, off, on, off. Make sense? What we want to know is how much water is in the hose when it's on. How much pressure is there? How much water is inside the hose when it's off? How much pressure is there? This is the top number of the blood pressure. This is the bottom number of the blood pressure. Kind of got that visual? That's all we want to know here. That's all a blood pressure is. How much pressure is inside the artery when the heart contracts and makes a wave? How much pressure is inside the artery when the heart is at rest in between waves? Oh, why do we care? Take that same hose on the outside of your house, turn the water full force all the way on, leave it outside for 10 years in the Florida sun and weather. What do you think happens to that hose? It does. It breaks down. It will actually start to separate. The hose will split. Now it's no good anymore. When you have high pressure for a long period of time under stress, so like our hose, water going through full force for a long period of time under stress of sun and weather, high pressure, long period of time under stress, that hose split, so will this one. That's called an aneurysm. In the brain, it's called a stroke. Make sense? So do we want our hose to be under a lot of pressure all the time? Especially if we have a lot of external stress acting on it? Now, unfortunately, when you have high blood pressure, one of the things they tell you to do is try to eliminate your stress. Anybody ever go outside? Because there's lots of stress out there. I get stressed driving. Road rage is a thing because none of those people know how to drive. I get stressed at the grocery store because the price of eggs are like $7 now. Crazy. I get stressed when my mortgage comes in the mail because taxes went up and insurance went up. I get stressed when my cell phone bill is due. I get stressed when my cell phone rings and it's one of my kids' names on there because, oh my gosh, what is this going to mean? Life is full, modern life is full of stress. We have external stress. All of us do. When we have high blood pressure, the amount of pressure inside those arteries, combined with that stress, it makes our risk factors go up for things like aneurysms and strokes. So what we want to try to do is find high blood pressure. If we can find patients that have high blood pressure, I can't do anything about the stress. I can't fix that. But I can fix this, the amount of pressure inside the arteries. We can fix this with medicines. If we can reduce the pressures on the inside of the artery, we reduce the risk. Does that make sense? That's why we take blood pressures. Okay? Normal values for the top number when the wave is moving through, maximum pressure, 100 to 119 is considered normal. In reality, the lower the better. 100 to 119 is considered normal. On the bottom number, this is when the heart is at rest in between waves. 60 to 79 is what we're looking for. That's normal. So if I have a blood pressure of 104 over 66, is that normal? 104 over 66, is that normal? Yeah, we like those numbers. I haven't seen a number like that in forever on me. If we see 144 over 92, is that normal? What's wrong with that one? Too high. What would we do with information, observations that we make? Report it to the nurse. That's all we have to do. We have to know what normal is so that we can recognize abnormal when we see it and report it to the nurse. Good? That's all a blood pressure is the amount of pressure inside the artery when a wave is moving through and the amount of pressure inside the artery in between waves. And to measure that, we're going to use a device called a sphygmomanometer. There's a mouthful. We call them blood pressure gauges. That's easier to say, but its technical term is a sphygmomanometer. As you look at this gauge, you're going to see numbers along the outside marked in 20s. So this is 20, 40, 60, 80, 100, and so on. The big marks in between are your 10s. So this is the number for 20. This big one is 30, 40, 50, 60, 70, 80, 90, and so on. The little teeny tiny marks in between are 2s. So if I have a line here for 40, that's 42, 44, 46, 48, and 50. That's how we read this. I'm going to go over that again in just a few minutes. That's how we read this dial. So what we're going to do, as CNAs do normal. You remember me saying that? CNAs do normal. If we know a patient has super high blood pressure, that is not normal. That is not your task. Who does those blood pressures? The nurse. Absolutely. CNAs do normal. So as a CNA doing normal, I'm just looking for basic high blood pressure here. I am going to inflate my cuff so that the needle goes up to somewhere between 160 and 180. This is as far as I go. As a CNA, we don't go over 180. Not our job, not normal. Who does not normal? Nurses. We go to 180. That's it. We start to come down, and as we deflate and as this needle comes down, we're listening. Now, we're not going to hear anything at first. It's quiet, 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 thump. Where we hear that first thump, where the needle is pointing on the dial, when we hear that first thump, that is the top number of your blood pressure. We're going to keep coming down, thump, 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 thump. We hear lots more thumps. We don't care about those. We're not counting them. They don't matter. Thump, 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 thump. Don't care. What we're listening for here is our last clear thump. So thump, 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 thump. No more thumps. Where did we hear the last clear one at? That is the bottom number of your blood pressure. So the top number is where the needle is when we hear the first thump. The bottom number is where the needle is when we hear the last clear thump. Now, those thumps actually have a name. They're called Korotkov sounds. You don't need to know that, but it's a good thing to know, Korotkov sounds, but you can just call them thumps. That's fine. So we inflate to somewhere between 160 and 180. We deflate slowly, and it's going to be quiet. Now, this is really important. Remember, we're listening for our first thump. Our first thump. Well, first means that there's nothing before it. There's no thumps. And this is where a lot of students get really messed up. They inflate, they deflate, and they don't hear anything. And they'll go, I don't hear anything. I don't hear anything. Well, you're not supposed to. We're listening for the first. So, shh. Keep listening. Keep listening. Keep listening. Do you remember our top number was the normal was 100 to 119, right? So, guys, that's this right here. That's this right here. If it falls in here, it's normal. Remember, we went way up here. So we're coming down, and it's quiet, 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 thump. Don't stop listening because you're not hearing anything. Now, remember I said lower is better? We may have patients with low blood pressure. In that case, you won't hear thumps till you're way down here. If you give up listening, you won't ever hear it. So the biggest challenge for you, brand new, learning blood pressure, is don't stop listening. Good? Because a lot of students get really anxious about this. I don't hear it. I don't hear it. You're not supposed to yet. That's good for the patient. That's awesome for the patient. Keep listening. Good? Okay, so I know it's kind of hard to see, but if you're looking at this dial, our first thump was heard here. Can anybody tell me what number this is? This is the 100. So it's 1, 2, 3 little clicks above 100. What do you think that is? So 102, 104, 106. So our top number is 106. And we heard more thumps. Thump, thump, thump. We don't care about those. Thump, 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 thump. And then this was the last one that we heard. It is 3 clicks above 60. 66. So 106 over 66. Is that normal? Yeah. 100 to 119 on the top, 106 falls in that range. 60 to 79 on the bottom, 66 falls in that range. So 106 over 66, normal. We document it, move on. If it's not normal, what do we do with that information? Tell the nurse. Questions? Do you guys understand what a blood pressure is now? All right, let's learn how to take one. Jake, go ahead and pass out. Don't pass out. Pass out the blood pressure cuffs. We have a couple people that have theirs. If you have yours, go ahead and pull them out. We have loaners if you need. Okay. Okay, so there's 2 pieces of equipment that we're going to use to take a blood pressure. There's a blood pressure cuff and a stethoscope.
Okay, go ahead. There's a blood pressure cuff and stethoscope in there. You both have one. You've got one as well. Does anyone not have a blood pressure cuff? Here's a pen. It's going to be our fake arm for demonstration purposes here. Just go ahead and keep that handy.
Okay, we'll wait just a moment for her to come back. So I'm going to go through how to use both the blood pressure cuff and the stethoscope. When you're taking these out of your bags, if you have a little pieces parts kit, looks like this, just put it back in your bag and leave it. You don't need that. That's replacement parts for later in your career if you need it. All right, so 2 pieces of equipment. We need to learn how to use both, and we're going to start with our blood pressure cuff. So this blood pressure cuff is one size fits most. Oops, not one size fits all, one size fits most. But professional cuffs have a measuring guide built right in. One of the smaller sides here, one of the narrower sides, has a white stripe. This white stripe is your measuring guide to figure out whether this is going to fit your patient. So Jake, can I borrow you? So if I'm concerned, actually, can you slip your jacket off real quick? If I'm concerned that this cuff might be too big or too small for my patient, I'm going to take this white stripe. I'm going to have him bring his arm out, and I'm going to wrap this about 1 inch above his elbow around the arm, just like this. Now, I'm going to have you lower your arms so that they can see.
I'll turn a little bit this way.
Yeah, on YouTube world. So we're going to wrap this around the back of the arm, just like this. If it wraps more than halfway around his arm, it's too big. If I can't see either side underneath the arm, it's too small. So this has to be between 1/3 and 1/2 the circumference of the arm. So if it wraps more than halfway around, too big. We're not going to get an accurate reading. Thank you. If it wraps, if when I put it around, you can't see either corner like this, it's too small. Anything in between, this cuff will fit on. So if you're not sure, you can use that as a measuring guide. Good? Okay, there's a couple different parts to a blood pressure cuff. If you look at the front of the cuff, you've got a little tab. Down below the tab, you'll probably have an artery marking. It might have an arrow. It says right arm, left arm. It could be a line with a circle, but you'll have an artery marking. And then you got two things hanging off. One of them is a gauge. The other one is the bulb and valve assembly. So the gauge, remember it's a sphygmomanometer. On the back of it is a clip. If you press down on the bottom of the clip, the top magically opens. If you open that clip and slide it up the tab on your cuff, it will live there and it's less likely to fall off and injure the patient. Now, there's little prongs on here. Don't use the prongs because the prongs let it slip off. You want to open the clip from the bottom and slide it up the tab. This gauge is super heavy, guys. This gauge is heavy. Your patient's wrist is right below this gauge. If this falls on their wrist, it will absolutely bruise. And if your patient has osteoporosis, it will crush those little bones in their wrist. When you put a cuff on and take it off, this gauge has to be securely attached to your cuff to prevent injury to the patient. Good? Good. Now, the bulb and valve assembly, I'm going to get to in just a second and explain how that works. Okay. So this is what the bulb and valve assembly looks like. This is how we're going to put air into the cuff and control the air coming out of the cuff. This little dial is what does all the work. This just pumps air in. This dial keeps the air in or lets it out. And you are in 100% control of this dial. But when you're holding it, we have to hold it the right way in order to control it. So this bulb and valve assembly goes in your dominant hand. So if you're right-handed, it should be in your right hand. The bulb should be in your palm, but not like this. The tubing has to face up, not like this, like this. This dial, this silver dial, my thumb and index finger need to be on that dial. On the dial. We're going to turn it to the right to close it, and we're going to turn it to the left to open it. So close and open. When I pump this up and I put my fingers on this dial, I can't let go. Because if you let go and then you try to grab it again, it's going to adjust it too much in one way or the other. So the needle will either go woo and you won't be able to get the numbers, or it'll stop. So when you hold this dial, this silver thing in your hand, don't let go. Bless you. Don't let go. Make sense? Good. We're going to learn to move this, but it takes super tiny motions. I mean, think small and go smaller. When I inflate my cuff and I try to deflate it with my finger, my thumb and finger on this, I am moving it itty bitty amounts. Itty bitty amounts. If I open too much, that needle's going to go woo, and you're not going to be able to get the numbers. If that needle goes too fast, that's you. If that needle stops, that's you. You are in complete control of how fast that needle moves through that dial. Make sense? Now, we do not want our needle to stop. This isn't a crock pot. We're not going to like set it and forget it. We have to open this dial a little bit, 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 until it gets down to 0. But little bits. Good? Good? Okay. So righty-tighty, lefty-loosey. So we're going to turn that dial a little bit or all the way to the right to close it. We're going to pump it up till that needle gets up to somewhere around 160 to 180. And then we're going to slowly open it so that needle starts to come down. Remember, we don't go past 160 to 180. So we close the dial, we pump, that needle goes up, and then we slowly open it to let that air out. But let me show you what's happening inside the arm when all of this is going on. Because I find it's helpful if you kind of understand what's happening inside, what we're doing here. So you've got an artery running down the inside of your arm. When we put this cuff on, remember I said that the cuff has to press against something? Well, what it's pressing against are the muscles of your arm. That cuff is going to use those muscles because it's putting pressure on it to crimp off your artery, just like a straw, crimps it off. So when we put the cuff on and we inflate, that cuff is going to press in and cut off the artery. So now your artery looks like that. No blood's getting through. But the heart is still beating. Remember, the heart pushes out waves of blood. Your heart is still beating. So that means that all those waves are stacking up, kind of like a toll booth, stacking up, waiting to get through. They're just hanging out, waiting to get through. Right now, the road is closed. It can't go through. They're stacking up and waiting. As we open our valve and the needle comes down and the pressure starts to decrease on those muscles, that artery is going to open up ever so slightly. And you see this on the dial because the needle starts to come down. We're decreasing the pressure. So as we decrease the pressure, that artery gradually opens. And now waves can move through. So we are going to listen on the other side of that cuff. We're going to put our stethoscope on the artery below that cuff. And what I want to hear is that first wave when it hits the top of the artery underneath my microphone, which is a stethoscope. So we inflated the cuff, closed off our artery, deflated the cuff. The artery opens up a little bit. Waves start to come through. And I'm going to use a stethoscope and listen for that wave of blood hitting the top of the artery under my stethoscope. Wherever that needle is, when I hear that first sound, that is my top number. A wave was able to make it through. And I heard it. Now, because one can make it through, that means others can go. So we're going to hear more thunks. The first one is the one that we need to know. That's our top number. The rest of the thunks, we really don't care about. It's going to move freely. Thunk, thunk, thunk. That means the artery's open enough for those thunks to go through. So the first one, where the needle is our top number. We're going to hear more thunks. And eventually, because we're still letting the air out, that needle's still coming down. We're still letting the air out, still letting the air out. Eventually, we're going to get to a point that the artery is so open that those waves aren't hitting the top of the artery anymore. And we can't hear them because the artery's open. So where the needle was when you heard that last clear thump, that is our bottom number. After that, it means the artery is wide open, can't hear anything. So this is why if you put your stethoscope in and put your, the stethoscope here, you're not going to hear anything because your artery is wide open. You can't hear waves hitting the top of the artery because the artery is wide open. You're not going to hear anything there. Make sense? Because the artery is wide open. So we compress the artery up to 160, 180. We deflate the cuff that opens that artery little by little. We listen for the first thunk and the last clear thunk. And then there won't be anything after that. Good? Okay. That last thunk means there's no more sounds after it. So it's going to be quiet, 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 thunk, 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 quiet, 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 quiet. First and last. Now, some of you are going to have problems with the first one. You guys are my dreamers. Dreamers are people that have a hard time staying on task, hard time focusing. And what happens, because this takes a minute, right? So what happens is you inflate and you deflate and it's quiet and it's quiet and it's quiet. And I'm hungry, thunk. I wonder, thunk, what I should thunk have for thunk lunch, thunk. Maybe thunk. Talk about thunk. Oh crap, there's thunks. Where'd they start? So if you're the type of person that you have trouble staying focused, that first one is going to be super hard for you because it's quiet, 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 and your mind just starts to wander. Now, some of you are going to get the first one just fine, no problem. You got it. You're going to have problems on the other end. You will have problems on the bottom one. And you're my dancers. So people have trouble on the top, you're my dreamers. People on the bottom, you're my dancers. You're rhythm oriented. So if you have something that has a nice rhythm and you follow along, what happens when that thunk stops? If you filled in that thunk, you're not going to know. Well, wait a minute. Wait. Was that a thunk or did my brain make one? So rhythm people have a problem getting the bottom number. You see how that can happen? And then you're going to have people like me who has trouble on both. When I first learned to take a blood pressure, I struggled with this because my brain would wander because it was quiet and I'd miss the first one. And then I'd get into that rhythm and I was never sure, wait, was the last one really a thump or did my brain make a thump? So this is going to take you some practice. It takes about 45 blood pressures before you even start to get accurate. You're not going to be accurate today. You're not going to be accurate this week. But you have to put the practice in to develop that accuracy. Does that make sense? Is that good? Okay. So remember that when we stop hearing sounds, our artery is wide open. The waves are moving through, not hitting the top of the artery, so there's going to be no more sounds. That last thump that you hear, where the needle is your bottom number or diastolic. Top number is systolic, bottom number is diastolic. Then we just keep inflating until that needle reaches zero. This is actually kind of important because remember, if that needle isn't on zero, it's putting pressure on the arm. We've put pressure on that arm for a little while now. If you leave that pressure on the arm, and you'll do this because you'll get so excited. You'll inflate, you'll deflate, you'll hear the first thunk, 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 you'll hear the last, and then you'll leave the needle right there and you'll take your stethoscope out and you'll go, oh, I think it was like 122, or that arm is going to reach out and smack you because there's still pressure on it. Get that needle to zero before you get excited. Then you can remove your cuff and record your readings. So the number where we hear our first thunk is our top number. The number that we hear the bottom thunk is, the last thunk is the bottom number, and that makes up our blood pressure. So let's go over the dial one more time. Now that you know what it is, let's learn how to read the dial again. So you've got it marked in 20s. And notice it goes way up to like 300 and something on your dials. Do we go that far? If you take this needle all the way up, that is a tremendous amount of pressure against that arm. Tremendous. That's going to cause pain. What effect do you think pain has on blood pressure? Anybody know? Yeah, pain makes blood pressure go up. So if we are inflicting pain and we get a high blood pressure reading, that high blood pressure might have been caused by the pain, not because the patient has a problem. This is why CNAs don't go past 160 to 180. Over that hurts. The higher you go, the more it hurts. So we stop between 160 and 180. So they're all marked in 20s. Your big lines in between are 10. So this is 80, 90, 100, 110, 120, 130, 140, 150. Your little itty bitty teeny tiny marks are 2s. So if this is the line for 140, there's 142, 144, 146, 148, and 150. Can you point to a line on this dial for 127? Can you point to a line on that dial that is 127? Can you point to a line on that dial that is 63? So what does that tell you about reporting blood pressures? Should we be reporting odd number blood pressures? Even numbers. If you tell me that the blood pressure is 141 over 79, I know you're guessing. I know you are guessing. 141, there is no line on this dial for 141. Does that make sense? There's a space there. But I want to walk you through why humans can't get odd number blood pressures. Machines can, humans cannot. So let's run through this really quick so I can explain this. So we inflated, we deflated, we're listening, right? Our ear picks up a sound, thunk. That ear has to tell the brain, heard a sound. That brain has to tell the eyes, look at the dial. The eyes have to see where that thunk occurs and report back to the brain, hey, this is where the thunk happened. And the brain has to be able to work out what number that is. Do you think all of that can happen in this itty bitty teeny tiny space right there? No, we are not that accurate as humans. Make sense? The reason that I tell you this is I have seen an old nurse absolutely light into a CNA for reporting an odd value. And I mean, they were not nice about it. Not nice. I'm trying to spare you from that. Even numbers. Does that make sense? Now, machines can get odd numbers because they're way more concrete and analytical than we are. But we can't. So to recap, we're going to inflate to 160 to 180, deflate slowly, listen for the first thunk, that's our top number. We'll hear more, don't care. Listen for the last thunk, that's our bottom number. Deflate to 0, and then we'll document. Make sure you're deflating smoothly. This needle should not ever stop. And remember, that's all you. All you. If that needle stops, that's you. We got to move that dial. And that dial has to move pretty consistently throughout this process. We don't just open it up a little and hope for the best. As that needle starts to slow down, you're going to open a little more. As it starts to slow down, open it a little more. And this is where that practice is going to come in. We're going to practice on our cans in just a few minutes. And that will help you kind of refine your motor skills. But again, you're not really going to get this until you start working on real people. And it takes about 45 blood pressures. So now let's talk about the stethoscope. Remember, there's two parts to a blood pressure reading. There's a stethoscope and a blood pressure cuff. Your stethoscope is essentially a microphone. Now, there's a lot of errors that happen with stethoscopes, and I want to go through this. So please don't try to get ahead of me at all. Stay with me because you may learn something through this process. So it's essentially a microphone. Now, the problem is that I only want to amplify what I'm listening to, the part in the body. I don't want to amplify all this stuff out here. People jiggling their legs, rustling papers, the AC. I don't want to amplify that. I just want to amplify what I'm trying to listen to. The problem is there's two sides to most stethoscopes. That means we have to tell the stethoscope which side we want to use because it's only going to amplify one side of this at a time. So most stethoscopes, not all, some of you have single stethoscopes, but most stethoscopes have two sides to them, like this. If you have two flat things, these are called diaphragms, right? These are diaphragms. If you got a curved thing on one side, that's called a bell. And it's to listen to different frequencies. As CNAs, we don't need this part. We just need the big diaphragm. That's all we use. The big side. We don't use a small side. We use the big side. Okay? Now, if I have to tell the stethoscope which side I want to listen to, and I want to listen to the big side, that means I've got to position the head of the stethoscope properly. And if you look at this, there's a little dot on one side of your stethoscope. Little dot. You want the large diaphragm to face the same direction as the little dot. This whole thing turns. The whole thing turns. Good. So you want to make sure that the dot is facing the same direction as your large diaphragm. Now you have a Littman. Your Littman may not have a dot. Littmans usually don't. Oh, you're missing your diaphragm. What happened to your diaphragm?
What goes over here?
Yeah. Oh yeah, you do have a dot. Oh yeah, you need that on there.
Okay.
Hold on, guys. I'll be right with you.
Let me do it.
You got to get that all the way around.
underneath,
Yep. Okay. So you want to turn your stethoscope so that your large side is facing the same direction as your dot. Questions so far?
You were saying about if they don't have a dot. I have a Littman
Oh,
too.
you have a Littman? Okay. So your Littmans are a little bit different because Littmans are used for more for professional. So for Littmans, yours is really hard to see. Yeah. Oh, well, yours is a single. Yours is single because you don't have the other head. So yours is always set to that one. The double-headed Littmans on one side, you actually have to look through the hole and see if it's open or closed. So Littmans are a little more challenging for beginners. Good quality though. Okay. So you want to make sure the large diaphragm and the dot are on the same side, but the ear tips actually are the part that makes the most difference in trying to hear this. I want to remind you that we are listening for a wave of blood hitting the top of an artery buried under muscle, fat, and tissue. This is not a big sound. We need a big microphone, and we need that microphone to push that sound directly to our eardrums. Now, the problem as adults is that our ear canals are not straight. Our ear canals actually angle forward. Like my ear canals are like this. They're not straight. But when we put stethoscopes in, we tend to do this. And that's just going to funnel that sound at the wall of your ear canal. It's not going to put the sound where we need it. So your ear tips, if they're straight like this, need to be adjusted. The way to do that is we're going to hold the little chin strap thing here. Oops. Some of yours are already curved. So if yours are already set, if your ear tips are already curved, just leave them. Yours are already set. But if they're straight, we have to adjust them. So we're going to hold, where is it? Okay. We're going to hold the chin strap thing here, and we're going to take our ear tip and just turn it slightly forward. All right. See how mine are now facing forward instead of straight? You guys see that? Good. When you put these in, we have to put them in with those ear tips facing forward, away from you, toward the patient, like this. Okay, we don't put them in like this. They don't go in like this. They go in like this. Ear tips facing away from you. So put your ear tips in and then tap on your diaphragm. And you should hear it pretty well. Now, take your ear tips out. Turn the whole thing around. Just turn the whole thing around and put them in backwards and do the same thing. You probably can't hear it as well. So turn back around, put it in forward, and do that again. Do you see how that's going to affect how we hear what we're listening to? Yours might be just a little bit too far. Yeah, let me just help you here. There you go. Got it? All right. So good? When you put your stethoscope in, those ear tips have to face forward, not backward, forward. So just turn the whole thing around, just like that. Put them in. Tap. Take them out. Turn the whole thing around. Put them in. Tap. You probably can't hear it as well.
Right.
So take them out. Turn it all the way around. That's how they go in. Ear tips have to face away from you. Now, I make a huge deal out of this because when you go home today, you're probably going to take your stethoscope out of your little case and you're just going to shove them in your ears and you're not going to be able to hear anything. And then you're going to get frustrated. If you can't hear thumps, check this first. You probably have your ear tips in wrong. If you still can't hear thumps, make sure that your diaphragm is facing the right way, that you're amplifying the right thing. If you still can't hear thumps, it might be your patient has really deep arteries and you just can't hear the wave of blood hitting the top of that artery. But check your ear tips first, then your diaphragm. Good? Make sense? All right, let's see if we learned what we needed to learn here before I let you loose. So in your book, on page 57, there's a gray box in the second column. I want you to look at number 8. I know they're kind of hard to read because they're black and white, but look at number 8. There's a graphic there. It shows you where the first thump and the last thump were heard. Can somebody tell me what this blood pressure is? 130/90. Everybody getting that? Is that a normal blood pressure? No. And I know that because if I look just straight over in that first column, the first paragraph gives me my normal readings. 100 to 119 on the top. This one's 130. 60 to 79 on the bottom. This one was 90. That is not a normal blood pressure. Let's go down to the next one. What is the blood pressure for number 10? It's kind of hard to read, I know. But it's one small mark below. So look closer at the top one. 108/62. And you did something that most people do. Remember, this needle is going down backwards. That means it's counting down, not up. Does that make sense? So if you've got 120, the one below it's going to be 118, not 122. It's always counting down. In most settings, CNAs will be taking automated blood pressures. You use a machine. In a hospital, the machine is mounted usually to a wall. In a doctor's office, it's mounted on a cart. In a nursing home or assisted living facility, it's a rolling cart. But most of the time, CNAs use a machine. But you have to know where to put the cuff. You have to know what normal and abnormal is. And you do need to kind of know what's happening with the blood pressure, what's happening in the body so that you can measure it effectively. But in most cases, you're going to take automated readings. If that automated reading is abnormal, if we get 140/90, you have to know how to take it manually. Because if you go to the nurse and you say, yeah, the blood pressure was 140/90, as a nurse, I'm going to treat that. But how do we know for sure that that's really the patient's blood pressure, that it's not a machine problem? Because what if the machine's batteries are low? What if the machine got knocked over and is out of calibration? What if the machine was left outside and has moisture in it? When we get an abnormal reading with a machine, we aren't sure whether it's a machine problem or a patient problem. And the only way to find out is to double check it manually, which is why you have to learn how to take manual blood pressures. Make sense? Make sense? Okay, so when we're taking the blood pressure, we have to put our stethoscope, the big diaphragm of the stethoscope, over the artery. Remember, we're listening for a wave of blood hitting the top of that artery. We need to be over the artery. So now we got to figure out where that artery actually is so we know where to put our cuff or our stethoscope. Your artery is not where you think it is. If you hold your arm out, get that elbow straight. Don't let it sag. Get that elbow super straight. At the fold of your elbow, 2 fingers, never your thumb. At the fold of the elbow with 2 fingers, we're going to go on the inside of the elbow, not in the middle. On the inside of the elbow, basically follow your pinky up. That is where your brachial artery is. So if you put 2 fingers there, thumb on the back, see if you can find your brachial artery. Those of you who have sweatshirts on, you may have to take them off to feel through it. See if you can find your brachial artery. You've got to make sure that elbow is up. If it's sagging at all, you're not going to feel it. That elbow has to be up and straight. No, not to find the artery. Yeah. You want to make sure, so you're good placement, but you're a little too high. We want to be a little bit lower right there. Thumb on the back. You're a little too close to the middle, I think. More right here. Right there. Good? Find it? No? Okay. We want to be way up here at the lines. Do you feel how hard I'm pressing? Mm-hmm. Okay. So what I did with you, watch what my fingers do. Now, the reason I do that is because when we have a lot of musculature there, and you've got a lot of muscle there, what we want to do is move the muscle and the tendon out of the way so that we're over the artery. So if you just lay your hand there and you don't feel anything, if you just kind of wiggle back, forth, center, it'll help you find that artery a little better. Got it? Find somebody else's. Grab an arm. Way up. Thumb on the back. A little harder. Yep. Got it? Now, are you guys noticing it's not right in the middle? It's on the pinky side. It's not right in the middle. So if you just put a cuff on somebody and you slap your stethoscope right in the middle, you are not over the artery. So chances are you're not going to hear the thumps as effectively as you need to hear the thumps. Make sense? When you're putting your stethoscope there, where you felt the artery, you really want to push this stethoscope down. You want to sandwich it against the skin. So I'm not just going to put like a little finger up there. See how that pops up? That's going to let air in. Air brings sound. What I want to do is take 2 fingers and really clamp it against the skin. You want to block out all air from getting under that stethoscope. It's got to have a good seal against the skin to be able to pick up what we need to pick up. So, used to be, years ago, we would take a pen. We would find the artery. Oh, there it is. And we would put an X marks the spot. Now I know where to put my stethoscope because there's the artery. I found it. I put an X. There's the artery. Your patients don't want you marking on them. So we went to the manufacturers of blood pressure cuffs and we said, hey, can you give us a marking somewhere on here that we can indicate where basically put our X on the cuff? And they did. They gave us these little arrows. Right arm, left arm. So now I lay this on the patient's arm. I find the artery. There it is. I line the arrow up with that artery, and then I secure my cuff so that it's snug against the skin. You want the bottom of this cuff to be about 1 inch above the lines of the elbow. Have you guys ever had your blood pressure taken and they put the cuff low and then they took the stethoscope and they shoved it underneath that cuff? You guys ever see that? Here's what happens. have a microphone on. People in YouTube world can hear me. Hi. The microphone does what it's supposed to do. It's amplifying my voice. If I do this, those people in YouTube world are hearing something muffled. This deadens the sound. When you put your microphone underneath the cuff and inflate the cuff, you are deadening that sound. Make sense? So you need your stethoscope out in the open. That means your cuff needs to be up above the fold of the elbow. So now what we're going to do is learn or practice inflating and deflating our cuffs. So we're going to take our cuff, we're going to wrap it around the can that Jacob handed out. I'll use my cup. Do we have?
It's gonna be weird with that one. We have just enough cans, but there's extras here.
Okay. Perfect. Okay.
Oh, you need one as well? Gotcha.
So you're going to wrap your cuff around your can so that the tubing hangs down. Oops. Okay. Yours is a little bit different. Yours is a home cuff, which can absolutely can be used. Leave that off. What we're going to do here. Home cuffs are a little bit different. They allow you to be able to take your own blood pressure. So you've got this bar on here. Don't take it off of the bar. It stays like this. We put this over our cuff. This may not work. I don't know if this is going to be big enough. Good enough. Okay, there you go. You're going to leave this there. Okay. So you have the cuff wrapped around your can. We're going to fold this extra flap behind, and you're going to hold it towards you. I'm facing it toward the camera right now. You're going to hold it toward you, just like this, with your non-dominant hand. So if you're right-handed, your left hand should be holding your can. Your dominant hand is going to hold the bulb and valve assembly. Now I'm going to stand with my back to you so that you can see, like, you know, it's not mirror image. Jacob, I'm going to need zoom. Okay. So this is, yeah, this is my bulb and valve. I'm going to try to keep this steady.
I'll bring it to you. Sorry.
You're good. That's good. That's plenty. Okay. I know it's a little bit blurry. But... Okay. Ah, there we go. Okay. So this is my valve and my bulb. I'm going to turn this to the right, righty-tighty, but don't tighten it. Just turn it till it stops. And then I'm going to pump up to somewhere between 160 and 180. I'm going to hold this valve, and ever so slightly, I'm going to turn it to the left. See how it's just a tiny bit? Do you see my needle going down? This is a, whoops, that's too fast. This is about the level that you want, right there. Right there. Now it's going to slow down. See how it's slowing down? I need to open it a little more. I need to open it a little more. I need to open it a little more until it gets all the way to 0. So close it. Pump it. Whoop, too high. Open it just a little bit. Little bit. It's really hard because I'm watching the camera, not what I'm doing. Little bit. This is the rate you want all the way down. And remember, I'm listening. I'm listening for thumps. The first thump I hear is top number. Last thump I hear is the bottom number. I want to go all the way to 0. Go ahead and give it a couple tries. Okay, you can bring me back to reality. All the way to 0. Give it a good couple of tries so that you have good control. It's all about control. Because this gets really complex when we start adding in listening. But give it a good couple tries. When you're comfortable, go ahead and take your cuffs off of your cans. Remember, you've got to be able to do this with one hand, guys. Your other hand's going to be holding your stethoscope. Let me see. Yeah, your bulb is.
I haven't checked on it. I'll have to get a new one. Yep, it's broken. Of course.
So a little tip, yeah, we've got one you can practice with here. So a little tip, guys, don't leave your blood pressure cuffs and stethoscopes in your car. Florida heat, this is made out of rubber. Florida heat tends to melt rubber, especially in a vehicle. And a lot of healthcare people leave their stuff in vehicles. Well, the constant cooling and heating of the components of this can actually knock it out of calibration or reduce the lifespan of your equipment. So don't leave them in your cars. I did for years as a home health nurse. I always left my stuff in cars, but I kept having to replace everything way sooner than I should have. So just a cost-saving tip for you. All right, when you think that you've got this down, go ahead and take your cuffs off your cans. And we are going to practice taking a blood pressure. So I'm going to do the first one to show you how to do this whole skill. And then after I show you this, you're going to break up into groups of 2, and you'll take their blood pressure, they'll take yours, and then you're going to switch groups. So for the next 30 minutes, you're going to take as many blood pressures on as many different people as you can. Okay? So, can I get a volunteer? Let me grab a chair here. Oops. Oh, I'm sorry. I'll bring it back. Go ahead and have a seat here. All right, so arms have to be supported. Remember I said we can't leave it out in midair? Arms have to be supported. So I'll get my blood pressure cuff and my stethoscope out. I actually think, I'm trying to figure out how to do this where everybody can see.
I can adjust the camera if it makes it easier. I can focus it on the bedside table if you raise it.
Yeah, let's do that. Let's do that. Because I'm going to stand in your way. You guys aren't going to be able to see through me. So at least you can see up there. That's good. Okay, can you put your arm up here? Now, if I have a choice, if the patient has either arm that I can use, left is always best. Left stays consistent. But if your patient has a condition where we can't use the left arm, like if they've had a breast cancer or, breast removal, mastectomy, if they've had dialysis with a shunt or a graft, if they've had a stroke with left-sided affect, basically we want the healthiest arm they have. So if I can't use the left, I'll use the right. For the purposes of this demonstration, I'll use the right just because it's over here at the camera angle. But if you have a choice left, how would I know if the patient has a reason I can't use that left arm? Care plan. You can also ask the patient, which arm can I use? So I'm going to lay this across the arm. I'm going to have her extend her arm out, find the artery. It's right there. My arrow lines up with where the artery is. I'm going to secure this so that it's snug against the arm. I'm going to put my stethoscope in with the ear tips facing the patient. Like that. I'm going to place this, go ahead and extend your arm out, on the arm. Jacob,
Yes, ma'am.
move the camera a little bit, please.
Yes, ma'am.
There we go. Okay. I'm going to inflate, deflate, listen for the first, listen for the last, go all the way to 0, and remove the cuff. Before announcing the blood pressure. Try to take my hair off. Very good. So that's how you take a blood pressure. So all of that instruction for a minute and a half worth of work. But that's how you take a blood pressure. Now, I'm not going to tell you what hers is because you guys are going to take it. And I want you to experience it. If I tell you what it was, that's kind of getting your mind cheating. All right. Go ahead and break up into groups of 2. And I know we've got an odd number in here. So one group is going to have 3. All right. So those of you joining us live, we're going to go ahead and there we go. Those of you joining us live, we're going to go ahead and sign off for today. Join us tomorrow at 11 a.m. for the game show. And Wednesday, we'll be back with another classroom session. Stay tuned for the new Pulse video that will be going live later this week. So make sure you take a look at that as well. Until next time, get your review sheets on flcnatraining.com. Till next time, happy caregiving. Bye.